Spotter 1.
We
Like to
request Dr. Salab Kumar sir and Dr. Seema Rekha Devi madam and Dr. Vijay Joseph judge to start the discussion. 10 minutes will be for the Salab Kumar sir, the panelist, and Seema Rekha Devi madam will contribute next 5 minutes asking questions. And Dr. Vijay Joseph sir, finally he will give the gist of the spotter.
Shalabh sir, I would like to request you to start questioning alternatively, sir. First question goes to team A and from PGs from AIMS Bhubaneswar, AIMS Rishikesh. Second question to PGs from AIMS Bhubaneswar. Shalabh sir. Hello. Shalabh sir. Hello.
I'll call him.
Okay, ma'am.
Hello. Unmute. the- unmute. Rohit, unmute, sir.
1 minute, ma'am.
Rohit is doing, sir.
Sir is already.
But your audio is not with. Your voice is not audible, sir.
Actually, sir has.
Yes, I'll ask Rekha ma'am, and
So
you
in the
please
meantime, we'll ask Rekha ma'am to continue.
quit and again rejoin.
I would like to request Seema Rekha ma'am to start questioning.
Madam, you please start. Sir will again join.
Right.
Okay. Good afternoon, everybody. I think team A, I'm asking the question to team A.
Yes, ma'am.
Okay, ma'am.
ma'am.
Yes. So please spot the diagnosis in these two cases. How will you diagnose and on what basis?
The first image is a image of healed facial burns, which is showing hyperpigmentation on the central portions of the face and hyperpigmented scar on the neck region, and it is involving the entire face, neck, as well as part of right shoulder and right side of the chest.
Why do you say, did you say?
Madam, one question at a time. If you
They
are
don't
satisfied,
answer
okay. Otherwise, you can ask other team to
Okay.
supplement, or is it correct, or you they want to tell anything
Okay.
different.
Okay. So, yeah.
What about second case? The team
Yeah.
can tell.
Yeah,
Team
the
B.
team, yeah.
You want to
Pass it
add
on to
something?
team
Then
B.
That goes to team B
Team
or
A has to complete the answer. Second photo, they have to tell the
they
diagnosis.
have to tell the diagnosis. Yes.
So
Okay.
what about the marks?
Marks
to team one?
said based on the answer they give to the
No,
second photo.
Dr. Seema, how much marks you would like to give to team A?
Sir, they didn't complete the answer.
They incomplete.
Team A, second photo.
They answered only the first photo.
Second photo, it is showing the patient is admitted and patient is on ventilator with showing with showing carbonaceous sputum deposition over the face with blackish discoloration, and
It is
suspected of
10% superficial, deep superficial second degree facial burns.
involving probably because the patient is intubated, must have mucosal injury and might have a component of inhalational injury as well.
Okay. Shall I ask the next question to team A or team B?
Madam,
Ma'am, if you are not
I
satisfied,
want the second team also to answer in this case.
Okay.
This is a case of second.
First photo, please.
The first photo, we can see singeing of the anterior hairline and the eyebrow. So this is a case of acute second degree, deep to third degree facial burns. And in the second photo, we can see similar facial burns with with inhalational injury. Therefore, the patient is intubated and on mechanical ventilation.
Okay. Ma'am, now you tell what is the marking you can give.
Scoring, madam. Scoring. Team A and Team B. How much?
Score.
How do I give the score? It's in marks.
Madam, first
Madam-
team, if the answer is full, it is 2 marks, and pass to the second team, half marks. That means 1 mark.
Okay.
Madam, do you agree with the answer given by the Team
No.
A? No.
Hello.
It's no, not fully.
No, sir. No, sir. No, sir.
So do we give only 1 mark to Team B?
Team A 1 mark, team B 1 mark, because the first photo is also acute stays only, but team A is told it is a healed
Healed
burns.
burn, yeah.
Okay, so the second team correctly answered there is a singeing and it is acute stays. So
Acute.
1 mark will be allotted to each team.
Yes.
Okay, madam. Okay.
now
Now
next,
the question to Team B, please.
So do I ask?
Team B, madam. Now the question to Team B.
Madam, ask. Sir hasn't rectified.
Am I audible now?
yes, sir.
Audible.
Yes, sir. Yes, sir.
Okay,
You
okay,
can
okay.
continue.
Okay.
One question is asked to the team A, so you ask the second question to team B.
So,
They told, madam asked about the diagnosis of 2 photos.
okay, okay. So, first of all, sorry for the delay and very good afternoon to all of you. My question is that what are the risk factors revealed by the history and physical examination for diagnosis of inhalation injury?
Team B,
Yes, ma'am.
On history and examination, we will observe for burns or facial burns over the lips, nose, singeing of the anterior hairline, singeing of the eyebrows, nasal vibrissae, any carbonaceous particles in the upper respiratory tract, any dyspnea, stridor, or hoarseness of voice or cough that is exhibited by the patient that can indicate towards inhalational injury.
Also, the nature of the cause of the
History.
burns and whether it happened in a closed room and whether there was any associated loss of consciousness at the time when during this incident has happened.
Yeah, so when the patient gives the history of sustaining burns in an enclosed space, or if he is in an inebriated state or he becomes unconscious so that he is not able to protect himself. And then the extent of injury, that what was the material which was burning over there, for how long he was exposed to this. Okay.
Yes,
So
sir.
all these risk factors, they point that the patient can have the respiratory burns, but it is not a must. Okay.
sir, anything you want to ask, answer is not complete, you can ask to the second team also. So they have the marks sharing.
No, I think this the answer is complete.
So
They have,
2 marks
So,
will be
2
allotted
marks
to
to
them.
Team B. Team
Team
B.
B.
Yes.
Okay.
Yes, madam. Yes.
shall I go to the next question?
Next question to team A.
Team A.
Yeah. So on the right hand side, you can see the patient is already intubated. Can you tell me what are the diagnostic tools for diagnosing this inhalation injury? Apart from history and the examination.
Apart from the clinical examination,
Yeah.
we can
The
do certain
diagnosis.
blood investigations like arterial blood gas analysis and in which blood lactate level and carboxyhemoglobin level, and we can also do chest X-ray or upper this
Indirect laryngoscopy.
indirect laryngoscopy and
Look for-
bronchoesophageoscopy.
Okay, you first said pulse oximetry and arterial blood gas analysis. It may be normal in the initial stages, it may not have. If they are normal, that doesn't rule out that this patient is not going to develop the injury.
Sir,
Yeah.
have they answered your question in their
No.
answer? The answer is there or not, sir?
No, answer is not complete. It is not complete.
So you can ask the second team to supplement it.
Okay, the second team, please, can you supplement it?
Yes, sir. We'll start from ABC, sir. We'll assess the airway.
No. Diagnostic investigations are asked.
For inhalation injury, diagnostic tools.
Tools.
Yeah.
Don't describe.
Bronchoscopy is done to evaluate the upper respiratory tract as well as the tracheobronchial tree for presence of carbonaceous sputum and soot particles.
Oh, they have already told
They
that.
already told.
They have told that. Yes, but
Team 1 told.
yeah. Any other? Although we are not doing that. But theoretically, you should know.
Carboxyhemoglobin assessment.
That's already told.
Already told.
Already told, but every patient should not have that carboxyhemoglobin. He can have inhalation burns without.
Anything other than what team A told, if you can supplement, you tell. Otherwise, no. We can go to
Would
the
you like
next.
to do a chest X-ray too?
Already it is told,
Can we,
ma'am.
ma'am, if possible, we would like to get a HRCT done.
And the
HRCT
blood cyanide level.
or blood cyanide levels.
What about bronchoscopy?
He told, ma'am.
Yes.
Okay. Fiber optic bronchoscopy.
Yes, fiber optic bronchoscopy, tracheoesophageoscopy.
Salab sir,
But-
I think what you want, they didn't tell
Can
you.
I add in this now? Can I add in this now?
Yes, sir.
You tell the marks score, sir.
Yes.
Then
See, the gold standard for inhalation injury, that is the fiber optic bronchoscopy. Okay.
yeah,
You said this pulse oximetry, arterial blood gas analysis, they may be normal in the initial stages. Same is the X-ray, it may be normal in the immediate period. It becomes positive only after 48 hours or so. So the gold standard is fiber optic bronchoscopy. Other things theoretically which you should know is the xenon 133 excretion. And then you can say something about this lung scintigraphy, the ventilation perfusion mismatch. So they can also be done, but usually these are not available everywhere.
they gave the answers, sir. So
Can we give the marks to team A?
Team A, yes.
Yes.
We have to give up out of 2.
2 marks, sir.
Okay.
You asked the diagnostic tools, sir.
Yeah,
but
yeah,
you would have added how you will diagnose also.
Yeah.
So do we give the full marks or only 1 mark?
Yes, ma'am, 2 marks.
2 marks. Okay, given. Now the question to team B, sir.
Okay. Now you see the patient on the right hand side. Can you tell me what are the indications of early tracheal intubation in cases of inhalation burns?
In case on presentation, patient presents with dyspnea, stridor, hoarseness of voice, they can be an indication towards involvement of the respiratory tract with carbonaceous sputum and an indication for intubation. Along with that, on fiber optic bronchoscopy, if we find carbonaceous sputum in the upper respiratory tract or carbonaceous sputum in the lower tracheobronchial tree, that can also help us identify inhalational injury, and that can be an indication for intubation.
Can you be more specific?
If patient has presented with wheezing or
Already it is told.
It's all given.
Other
Any
than what you
parameters?
explained, you tell. Otherwise, team A.
On bronchoscopy, if we are seeing mucosal ulcerations,
Okay.
You can team A, pass it on to team A.
Anything supplementation?
Yes, ma'am, in case the intubation is required for more than 7 to 10 days, so we would like to do an early tracheostomy. And if there is any
No.
ulcerations in
What
the
are the
mucosa,
What are the
indications?
indications? When
Indication.
indications is
In case of extensive burns with the facial injuries, in case of facial edema and the supraglottic edema on indirect laryngoscopy.
Okay.
Uh,
So you mean to say all patients of facial burns you will intubate?
no, sir.
Then
Any
Facial
parameters?
in case of facial edema with
facial
local
disfigurement.
signs and symptoms which are supplementing to the
No,
inhalational injury.
listen.
No.
Already
Any
team B
parameters?
explained. You have to supplement. Don't repeat.
Okay, ma'am.
Do you have any clinical parameters, any biochemical parameters that you want to think?
see, whatever you
Low albumin.
Sir, I think you can give the score and tell the answer.
I think 1 out of 2.
1 mark to the team B.
Yeah. Because whatever you are saying now,
Which you will ask for.
number first is that if the patient is having any overt clinical signs and symptoms of respiratory obstruction. Okay. So that is an indication. Or
They told
early
Slider.
or there is early hypoxemia which is not settled by supplemental oxygen therapy. Or if the patient is comatose, he is not able to protect, there is inability to protect from the aspiration, then also that's an indication of the intubation. Or you are suspecting the significant CO or cyanide toxicity. Okay. Every patient of facial burns will not, he may have some component of the inhalation component, but that doesn't mean that every patient will require intubation.
Sir, team B answered the Strider that indicates the obstruction.
Yeah.
And, they told the other features also, like acid blood gas analysis based on that also they told. So you want to give 1 or 2, sir?
1.
Only
Okay,
1.
sir. Now the question goes to
Question
team A.
goes to team A.
So, what are the indications of tracheostomy in inhalation burns?
Indications for tracheostomy, sir, patient requiring prolonged intubation for more than 7 to 10 days.
Yeah.
And mucosal ulcerations, facial disfigurement, and
Facial disfigurement.
facial disfigurement.
How
Failed
impact?
if there is any difficult mouth opening and severe facial edema, mucosal edema.
So mucosal edema will be there initially in almost whosoever requires intubation, they are also having the same features.
Yes, this disfigurement implies what actually?
In case of concomitant facial trauma, along with the blast injuries, in case of blast injuries. ma'am.
So
No,
instead
concomitant injuries we are not talking about. They may be
Neuro-
In case of neurological impairment with low GCS.
Sir, only 2 minutes left.
second.
and failed extubation, failed
Can
intubation.
If they are not telling you, please pass on to the team 2, team B.
In case
Team
of
B.
severe edema, so that the endotracheal intubation is not possible. In that cases, we can also do tracheostomy.
Or can
Any
you say,
supplementation by
Yeah.
team B?
Yes, ma'am. If on bronchoscopy there is extensive pulmonary involvement seen, grade 4 injury is noted, and or a patient is having any associated head injury, he is in coma, in which we are expecting a long stay and a long intubation period, directly we can go for tracheostomy.
Okay, that also we can accept, but that
any
is
other
a
point?
that is not because of this burns. You are saying head injury, no? That is a associate.
Comorbid, associated.
And grade 4 injury on the bronchoscopy, sir. Massive, extensive pulmonary involvement.
Or failure of intubation because
Or
edema
failure of
has
That
come.
team A told, ma'am.
Okay.
Okay, to this now one more thing, that whenever the intubation is required for a prolonged period, if you anticipate
That it was told, sir.
that is
Told,
So
sir.
team A gets 2 marks.
okay. Yeah.
Okay.
But the other is that when you are predicting multiple surgeries, then also you can opt for this tracheostomy, especially with the inhalation burns. If the patient has to go multiple repeated surgeries, then that will obviate the need for repeated intubation. Okay.
Now
Sir,
one more
one
question to team
is
B.
allowed.
To team B. To team B.
Team B. Okay. How can the ear be involved in cases of facial burns? What are the different pathomechanisms?
Sir, when there is heat which goes in the oropharynx or oral cavity, there is
Ear.
complement activation. Sir,
I'm asking about the ear. The involvement of the ear in facial burns.
hair. Okay.
EAR.
Ear.
EAR. Ear.
Would you repeat the question, please?
How can the ears be involved in a case of facial burns?
Ear, man, ear.
Yeah. When there is extensive facial burns and
Yeah.
ear, because it is underlying cartilage, cartilage is there. So because of the burn and the infection setting in can cause exposure of the cartilages and can cause ear deformities.
Yes. Suppose there is only partial thickness burns, cartilage is not exposed.
Raw areas present over the skin of the ear can cause adhesions and can impact on the structure of the ear and lead to constricted ear or further contractures.
Can ear be deformed in a case of partial thickness burns of the ear?
Yes, sir. During the
So
healing process,
how does that happen?
during the healing process, when the cartilage can get exposed later on, or because of
The cartilage is not getting exposed.
Sir, allow the second team to answer.
Second thing,
Because
Team A.
No,
skin
yeah.
ears are exposed parts protruding from the facial face, and then there is a thin skin over the cartilage, which has less vascularity. So even exposure to less amount of heat can cause deeper degree burns in ear, and can expose the cartilage, which will lead to avascular necrosis of the cartilage. So, and
I am asking, can the ear cartilage be involved without getting it exposed or not? There is a partial thickness burn of the ear.
okay.
Can the cartilage be still involved?
It is not exposed. What superficial
Maybe
burns.
yes, sir. Because of because the
adherent to
it is thin subcutaneous tissue with
adherent to the cartilage.
so the vascularity would be compromised, and as cartilage derives vascularity from the perichondrium, and if it is involved, then there can be
But you can
necrosis of the
explain it
cartilage.
in a better way.
Can be
And
result in
increased
perichondritis
risk
of the
of
ear
back
cartilages.
infections due to loss of barrier function of the
Sir, time is over, sir. Please tell the answer and give the
Okay.
score.
See, the ear can be involved. If it is a full thickness loss of the skin, the cartilage will get exposed and then it can get deformed. But even in superficial and partial thickness burns, what happens? The fluid collects between the skin and the cartilage. Okay. And this cartilage is driving its blood supply from the
Skin.
surrounding skin only. So it can be involved. And when this happens, this chondritis happens, it happens 3 to 5 weeks later after sustaining the burns. It doesn't happen immediately at that time. Whereas in a full thickness burns, when this ear will be involved, it will be at the time of the injury itself. Okay? So you have
So-
to know the difference in these two.
So perichondritis.
Yeah.
Okay. Sir, any marks for any team or no?
I think 1 mark for the in first team.
Team B.
Okay, sir.
So now, sir, thank you, sir.
Thank
We
you.
invite Seema madam to ask questions for 5 minutes.
Okay. So now patient has come and you have diagnosed. Immediately, what will be your reaction? This is to team.
A, team A.
What will be your reaction? How you are going to manage? We have talked about already diagnosis and all those methods. But what will you do when you see a patient and you suspect the patient is having inhalation burn? What would you do first?
So firstly, assess the airway, breathing, and circulation, ABC, ma'am. And if we suspect inhalational injury, we would like to start nebulization with heparin and N-acetylcysteine and Duolin to avoid bronchospasm. Heparin to resolve the microthrombi that would occur in the airway. And,
The
and
first
start
thing,
the patient on oxygen, supplemental oxygen therapy.
I think the first answer on that would be first is oxygen supplementation.
Oxygen therapy
Oxygen.
followed by
Then only you go
nebulization.
for others.
Yes.
Isn't it?
Can we give the marks to them,
Yes,
madam?
You can give 1 because first and was missed.
Okay. Now the question goes to team B.
Ma'am, ask fast. Time is running.
So, as you know, this patient you have intubated, and then when you are going to do a definitive, patient is otherwise stabilized, and the face, what is the depth of burn in face? And how will you calculate the percentage of burn in such a patient? Because what you have seen some and you have not seen some percentage. So what will be your calculation for percentage of burn? This is
Team
to
B. Team B.
Face has a very good blood supply, ma'am. Therefore, sometimes depth calculation is difficult. Once the patient is intubated and the airway is secured, we will dress the wound, and we will clean the wound properly and try to assess the involvement of the surface area of involvement of the wound, whether it is 2nd degree or 3rd degree, and then go forward with an exposure dressing for the face.
What about, I asked for calculation of the percentage. Face-
Percentage, we can use the rule of 9, ma'am. And so after examining completely, face will have around 4.5 to 5%.
Agreed. Face burn, you can use rule of 9, but there is some hidden burn in such cases. So fluid calculation will also be, different in such cases. So what is the hidden burn? It's the mucosa.
The upper respiratory tract mucosa is involvement.
Okay,
have missed that.
anything you want to supplement, ma'am wants, how you will estimate the fluid resuscitation? That is the answer
Yes.
you have to give.
For fluid resuscitation, we'll keep the percentage, we'll keep a rate as 5 to 10% of percentage surface area burn, and we'll calculate based on 10.
Because this has the importance. You give more fluid because there is also a respiratory tract burn. But in that case, immediately it will give rise to edema, isn't it? And then intubation will be difficult.
Ma'am,
So this
you can ask other team also to answer.
okay.
Yes,
So
So,
anyway, team A or team B?
Team A has, do you want to supplement?
Yes.
We would like
Yes.
to add the mucosal surfaces of inside the
Oh,
nose,
yeah,
as well as the oral mucosa, upper respiratory tract. Those are the additional hidden areas that could have been burned.
Corneal burn injury.
And
This
So
how
now
will
how will
you
you calculate?
how will you
calculate.
calculate?
Mm.
If you know, you tell. Otherwise, just pass.
Team B?
Ma'am, we'll
Madam, it's
be
a question to
That
team
would
B
be-
only.
Team
So,
B,
ma'am, now you can answer.
yeah. So as that is the hidden area, we do not know exactly the percentage of burn. So we have to give some extra fluid in relation. We do not know how much is the burn. So we have to give some extra fluid and monitor the patient, otherwise this will give rise to lots of edema. And afterwards, if you want to try to intubate, that will be very difficult. So not only the percentage, you say if the face is, 9, you calculate as rule of 9, but then some hidden, 4 or 5% areas will be hidden. So you have to add that fluid also so as to properly calculate the fluid.
Sir, ma'am, the second team already they told the answer. Additional 5% they told. So
Okay.
that they can be given marks.
Okay.
As time.
Can I add something into it?
Sir,
Madam, what is the mark that we give
2 marks, ma'am, to team B.
to team B? Okay.
Yes, yes. They answered.
Yes.
Percentage after asking like resuscitation, how they will calculate, right?
Yes.
Now we invite Dr. Vijay Joseph, sir, judge of this spotter. Sir is available?
Good.
Sir,
Yes, ma'am. Yes, ma'am.
kindly give your gist, how to go
Sure.
about this case.
Sure. So I'll start with the patient on the right,
Sir.
who is an acute facial burn predominantly with some burns in the rest of the body. He is already intubated. So the question about how do you decide whether to intubate or not? When you have extensive facial burns with all the things that you said, singeing of the hair. So the main thing is edema. So you're anticipating that the supraglottic edema and the vocal cord edema is going to make it difficult later for us to intubate. So we tend to intubate early before that edema sets in. So bronchoscopy is an excellent diagnostic tool, like Professor said. And in the bronchoscopy, you're looking for hyperemia, ulcerations, and later on only would you see the casts and the sloughing of this thing. So at the upper level, which is glottic and supraglottic, or at the lower level, which is much lower down. We, as far as possible, would avoid a tracheostomy because tracheostomy comes with its own other complications. The other thing that you have today is that you can use low pressure endotracheal cups, and you can also monitor the pressure of the cups. You can intermittently deflate the cup because you don't want to have trauma to the vocal cords and the trachea and from the larynx from the cup pressure. Coming to the how much fluid to give, we still would go by the fluid of calculating of either the 4 ml per kg or 3 ml. and you watch your response of the patient. You have to keep a watch on for early signs of pulmonary edema. And our critical care people who manage this would do constant ultrasound examinations, looking for B lines to see if there's any evidence of fluid overload. The oxygen, you give high ventilation, high percentages of oxygen in the ventilation. The bronchoscopy is also done for bronchiolar lavage in cases of extensive inhalation burns. We would use bronchodilators, N-acetylcysteine, nebulization, and heparin nebulization, all of them simultaneously. To diagnose the carboxyhemoglobin and cyanide is a little more difficult because they're not always available. But if you find that there's a disproportionate rise in the lactate level, much more than what you anticipated, and it's continuing to rise, you could suspect a cyanide poisoning also from what burnt in the, if it was plastic, if it was wool, if it was silk, then there are high chances of cyanide in the blood. And empirically, you can give hydroxycobalamin intravenous, which helps to remove the cyanide as well. So when you have active accessory muscles of respiration, extreme tachypnea, hoarseness of voice, and evidence of face and neck edema, you need to very quickly look at intubating these patients. If the patient is comatose, also an indication to have the patient intubated because you don't want anything to aspirate in these patients. One of the teams mentioned in the figure on the left that there was hyperpigmentation. You need to be careful about that because this really doesn't look like pigmentation. In our Indian skins, when you get a fairly superficial burn, the skin actually looks that color and then it'll peel off. Like on the forehead, you can see that it would have been the same color there and it is peeled off. So a lot of this will clear to the pink color over there. The one on the shoulder and the pectoral region could be a hypopigmented patch in the this thing. Then the next question is there any role for early primary excisions on the face? Most often we tend to be conservative on the face because we find that a lot of it heals primarily. But if you do have to excise, you would again try and excise in the aesthetic units and resurface in the aesthetic units. The best result seems to be from patient healing. So you have to be very careful about the depth of assessment whenever you plan primary excision. I think that's all that I have to say.
Thank you, sir. Rohit?
PGs, ma'am.
Yeah.
I'll move to the PG session. Now, team 2, for Gangaram Hospital, your question to team A. PGs,
What are the bronchoscopic grading? Can you grade the inhalational injuries bronchoscopically?
Team A.
There are 4 grades. Grade 1 is edema involving less than 25%, and grade 2 is there will be severe. Grade 1 will have erythema, and grade 2 there will be severe erythema with edema and blistering. And grade 3 there can be ulceration and necrosis, and grade 4 there will be involvement of subglottic structures beneath the trachea and upper respiratory tract, lower respiratory tract like the bronchi.
It's partially correct.
1 minute. Team B.
Team B?
Supplement.
Can you come?
We start with 0 where there is no suit in the upper respiratory tract. Grade 1 or mild is where soot is present in the upper respiratory tract, can lead to laryngitis. Grade 2 is moderate, where we have involvement of the tracheobronchial tree, patchy involvement. Grade 3 is severe, where we have dyspnea, stridor, and wheezing cyanosis. Grade 4 is massive, where we have extensive pulmonary involvement and airway obstruction.
Okay.
I mean,
So
we
what
can
is the
mark
mark?
Marks.
half of you can give him, I think.
Okay.
Yes.
Now, team 4, Sage GS Medical College, your question to team B. Team 4, PGs from Sage GS Medical College.
Hello.
Yes, you are audible.
Please ask.
Hello.
Yeah, please ask the question.
My question is, what is the exact mechanism of supraglottic and infraglottic airway involvement? How is that different?
Team B.
Supraglottic is from the heat source directly, and subglottic is from the products of the combustion. So the direct when there is exposure to the source, the direct injury will be to the supraglottic, causing the supraglottic burn. And from the products of combustion, the gases which are steam gases which come out will cause the injury to the subglottic airway.
Yeah, the chemical or the gases basically causing the infraglottic.
Yeah.
Yeah.
So full marks?
Full marks, ma'am.
Yes.
Team B.
Yes.
Okay.
Okay. We'll go to the pattern and
patterns.
question. Sir, Bhattacharya sir, would you like to ask?
Yes, team A said that it's a second degree superficial burn. Do you still hold it to be second degree superficial?
For second degree.
You said in your answers second degree superficial burn. Left picture.
Left picture is second degree deep burn.
No, it's a superficial burn.
Your word, see, each word has meaning. Second degree superficial, now you're telling second degree deep. Now, what is second degree superficial and what is second degree deep tissue-wise? What do you understand by
Second degree superficial involves the papillary dermis, sir, and there will be blistering with blanchable erythema. And second degree deep involves the reticular dermis and will have a non-blanchable erythema.
Okay, but this is second degree superficial or second degree deep?
Superficial. Second degree
Initially, you
deep
said
also
second
is
degree
a pearly white
No, no.
No,
Your
there is a
diagnosis, second
diagnosis.
degree superficial or second degree deep?
Second degree superficial.
Be fast.
Second degree superficial.
Superficial. Okay. So, this is a homicidal burn or an accidental burn?
So it looks like accidental burn because because of the blast pressure or something cylinder blast.
So, why not homicidal?
Homicidal burns also along with the face, it also has bilateral involvement of the these shoulders and chest because patient
Always. Suppose
always.
this is a chemical burn or a flame burn.
So it's looks like flame burns.
Why do you say so?
Because the singeing of hair, sir.
No.
And
Chemical burns, it has a typical texture of the depending upon whether it is acidic or the alkaline burn.
The
It
other
may
team?
have the
Team B.
Why not chemical? Other team.
So
Team B.
chemical
Team B.
burns,
Team B.
we will observe something called the trickling sign,
You
which
will observe
trickling sign, sir. The chemical
trickling
that gets
sign.
splashed
Yes.
will trickle down to
That's the answer. That's the
Answer.
answer. That's the answer. Okay. So trickling
Sir.
sign. Then
Question to
team.
team B, sir.
So
So what is the mark,
team
sir?
1 mark, madam.
Okay.
1 mark. So the left picture again, I'm there.
So
And
team B, sir.
Team
To
B.
team B.
And one team said that there is a depigmented area of the right shoulder and chest. Now, is it associated with this burn or not?
This doesn't appear to be associated with this burn, sir. It
Why?
appears to be a old. It is
Yeah, older hypopigmented healing.
healing.
Why?
Sir, already it is epithelialized completely, and there is along with it we can see surrounding contracture forms
Hypertrophic
also.
scar, yes.
Scar.
So that is an
Hypertrophic
old
scar
burn.
is there.
It has nothing to
Old
do
burn.
with this burn. Okay, correct.
2 marks. 2 marks, sir.
Right. In the face, in both the cases, what is your priority areas?
Is it going to team A, sir? No?
Team A.
Sir, time. If
Time.
you don't mind, there's no time, sir,
Okay,
please.
okay.
So we'll go to the next spotter.
Okay, ma'am.
We invite panelist Dr. Anjana Malhotra, Director HOD of Plastic Surgery, SCR Central Hospital, and Dr. V. Bhattacharya, sir, as moderator, and Dr. R.K. Srivastava, sir, retired professor, Safdarjung Hospital, as judge.
Good evening to everybody. Good evening, sir. And my question to team is, this is a 7-year-old boy. So calculate the percentage of burns in this child.
So,
The back also involved.
The whole of the back is also involved.
13
Only the face and the lower part of the limbs which you see is free.
is 2.5.
So, in children, head and according to London Broader, head and neck would involve 18%, which is spared. So 18% is spared, and both the legs and the soles are spared. So that will be around 5.5 on each side. That will amount to 11%. So 18, roughly 70% total body surface area. Second degree superficial burn.
Back and buttocks, we can
Including
Don't-
with genital parts.
Okay, correct. Team B.
2 marks
The
given to the A. A.
Yes, madam.
Team B. Question to you. This child's genital area is burnt. What problems do you expect there, and what would you do?
We like to avoid doing tangential excision early. We like to treat it first conservatively. Keep a Foley's catheter for a long time to ensure that the ureter is not being contracted from around.
Since the skin over the perineum and the genitalia is thin, comparatively thin, the chances of infection is more. So we would first of all like to keep it clean, and exposure dressing would be done with a topical antibiotic ointment. The patient should be catheterized. And as he said, early tangential excision should not be done in that area.
What about the stool? Team B, do you want to add anything? I mean, Team A.
Yes, ma'am. In case of perineal burns, there will be risk of long-term complications. Could be stricture formations in the urethra, urethral fistulas, and there can be contracture around. There can be perineal, anal stenosis can occur, and urethral stenosis if it is not catheterized. So
social stigma.
and
So you
there can
still haven't given the answer. I think team, the team which answered first will get 1 mark. The second team shouldn't get anything. See, in the perennial burns, you have two things to look after. Not only this urine, but also the stool. The urine is easy to look after because you're going to catheterize. But it's the stool which is going to cause problems, isn't it? So you have to give a soapy wash after every stool, keep the area dry, and ensure that because stool is likely to contaminate, there's likely to be bacterial contamination. Now again, question to team B. I think team B's question. In
No,
a
madam.
team
It
B, right?
goes to team A. Team A only.
Team A,
You
okay.
asked one question to team A and the second to team B, and the question was
Again, team
passed
A.
on to
Okay.
team A.
Okay, team A, sorry. So now in a pediatric burn, what other thing you should look out for? There's something special to children which you should ask for in the history or be careful about. Team A?
A history of seizures, absent seizures, or there can
No, I'm talking about the method of burn, the type of burn. There is something very categorical in children. It's for all trauma. I'm giving you both a hint. So what you should
Yes.
be
It can be homicidal burn in case of like what baby syndrome, like battered baby syndrome,
Yes,
and
correct. So that is called child abuse.
yes,
So
child.
what typical distribution do you find in a case of child abuse?
Um, uh, mainly to mainly over the face and the exposed areas, and and they are
Yeah, so
repeated
it's in a
repeated
stalking
attempts.
distribution. Stalking
And
distribution. So 1 mark to team B.
Team A, madam.
No,
Team
the
A.
question went to A, no?
The primary question was to team A, and they only answered.
No, they didn't answer. Team B answered. So team B will get.
ma'am, we are team A.
Your
We are
team A.
team A.
Okay. Okay.
So shall we give the full marks to them or half mark?
Yeah,
madam?
1 mark, 1 mark.
1 mark. Okay.
Yeah.
Now the question to team B, madam.
Okay. So team B, your question is, what happens, what is the peculiarity of pediatric burns regarding their depth?
Ma'am, the thickness of the skin in pediatric age group is almost around 70% of the adult skin. So the depth will be, the involvement will be more compared to the child, and also during the calculation also because of the weight and the surface area, as per the weight compared to an adult, the body surface area involvement is more.
Which leads to more evaporative and heat losses.
Yeah, so absolutely correct. So they get 2 marks. So
Okay, madam.
now, question to team A. So
Yes, madam.
what are the sources of infection in any burn? I mean, in pediatrics or otherwise?
they are mainly two types: exogenous sources from the wound environment, from the dressing trolley and the surrounding like from the nursing staff and from the cross contamination, and other from the endogenous sources like because of this contaminated urine and the stool and
respiratory secretions, nasal secretions.
In B?
It can also be from the wound, the entire raw area which is exposed from the dressing.
Means the skin barrier goes, so they
Yes,
get
sir, from the
infected.
wound.
Yes, then
So exogenous infections.
It can be nosocomial while changing of dressing, if not adequate hand hygiene is not maintained.
that they have already told. Apart from that, what are the sources of infection which you have to look out for when you're treating these patients over 2 weeks, 3 weeks? These are the places from where you have to search when the patient suddenly develops high fever. So that is what I'm trying to ask you.
Soil dressings, any soil dressing with stools or cross contamination due to the
They have already
caregivers.
They
answered all
already
those.
told.
That is
Urinary leak
answered.
from
No,
the
I think
catheter.
then team A will get
Catheters.
one,
Uh,
team B doesn't get any marks. The other sources are you have to look out is bacterial translocation occurs from the gut. Okay, so that you have to be careful about. Urinary catheters you told and the wound we all know. Very important is IV lines. The
IV
central
line.
lines, the IV lines, these are all sources of infection. So you have to look at that. And also when a patient is on a ventilator, then you have to think of ventilator associated pneumonias. Okay.
Question to
So
team B.
yeah, question to team B now. What is the classical triad of SIRS? When do you think, there are three things which occur in a patient which makes you think that patient is having SIRS, systemic inflammatory response syndrome. So what is that triad?
First is the temperature of the patient. If it is less than 36 or more than 38 degrees Celsius, then if if the heart rate is more than 90, and if there is the WBC count is less than 4,000 or more than 12,000, then we'll consider. And if the respiratory rate is more than 20 or the PCO2 is less than 35, then we'll consider it to be SIRS.
Yeah, absolutely correct. 2 marks. So, a small question here. Does fever and leukocytosis in a burns patient always indicate SIRS?
No, no, ma'am.
It does
Yeah,
not
because
indicate.
it can occur in burn patients without SIRS. So,
Yes, ma'am.
question to the next team.
Yeah.
Yeah. So which anesthetic agent is absolutely contraindicated in you are going to take this patient to OT for repeated dressing changes for early burn wound excision and all. Which anesthetic agent is absolutely contraindicated in acute burns? And why?
Saxena and Foley.
Correct. Why?
Hyper. No, malignant. It causes rise in the potassium level.
Correct. Hyperkalemia leading to cardiac arrest.
Yes.
Absolutely correct. 2 marks to you. So that is team A. Now question I think goes to team B, right?
Team B. Yes,
Yeah.
madam.
So team B, question to you. How much should be the urinary output be maintained in pediatric burns?
1 to 2 ml per kg body weight, ma'am, should be the
Why? In an adult, how much would you maintain it at?
0.5 to 1.
Yes. So why?
More surface area is
We have higher-
higher body surface area is there. When we are giving the fluid to a pediatric age group in the formula also, we are giving it more compared to a adult of the same.
Pediatric age group
So
has a lesser
more
reserve
surface
than
area
adult
compared
weight.
to the body weight,
Yes,
what we
ma'am.
are taking. So absolutely correct. So 2 marks to them. And a question to next team. What is the
Team
best
A.
team
Team
A?
A.
What is the best agent for pain management in burns? In other words, which agent is safe to give?
COX-2 inhibitors are mainly safe, and we can also give in small ones NSAIDs, and for extensive painful burns we can give morphine. But COX-2 inhibitors are safe.
Team B?
Fentanyl, ma'am.
No, I think I'll go with Team A's answers, though they told everything. But the safest agent to give is morphine. So morphine is the safest analgesic you can use in burns because of its metabolism, and it doesn't affect. It's not affected by the burns. So should I continue, Dr.
Madam,
Lakshmi?
Madam,
Uh-huh.
shall we give the full marks to the team A?
Yes.
Ma'am,
Then
one
more
question to team B.
Team B.
Yes, madam.
Okay.
That is
Okay.
last question.
Last question. Okay. So on the picture on your right, what type of burns is this and what stage is it at?
This is a second degree superficial to deep burn post most likely tangential excision, where we can see granulation tissue over the bed, and we see an area has already been grafted over the chest, which is taken up well.
Correct. And see, there is a dressing in the upper arm. I mean, could you comment on that? Left upper arm.
Is it a
It's not
peripherally inserted central line?
It's a
very good. Complete 2 marks to you.
Thank you, ma'am. I invite Dr. V. Bhattacharya, sir, to continue the discussion.
The picture on the right, what do you think is the mode of injury?
Team A. Yes, correct. So it
Mode of
it
injury.
is mode of injury could be scald burn, sir. In accidental scald burn.
Okay. Accidental
Scald burn.
scald burn. Okay, why do you say so?
Because it is involving only the trunk region, while taking bath or when the water without if water is poured on the baby without checking the temperature of the water, so it is usually from the shoulders down. So
Would
there
you
is
like
swelling of
to
face.
would you like to elicit any specific history regarding any previous disease?
About seizures, sir. If the baby had history of seizures.
Seizure. Correct.
Yes.
Full marks.
Question to team B.
Yeah. See this chest area above and below a raw area, and in the central part it is a dark area. What is it? Somebody says it's a grafted area.
Yes.
Do you
Yes,
think it's a grafted area?
Yes, sir. We can see a meshed graft over this
Okay.
region, sir.
So when do you mesh and when you don't mesh?
When we have to cover more area, if it is extensive, large wound, then we'll be meshing the graft. If we have scarcity of donor side area and more amount of raw area to resurface, then we'll be grafting. I will be meshing, sir.
And we don't
So
mention
suppose you have to
exposed areas.
prioritize the area of resurfacing, then how do you prioritize in this particular burn? Suppose this area has not been grafted. So which area will be a priority, thinking that you have a scarcity of donor site?
First would be
The anterior trunk would be grafted first, sir.
What about the testicles and perineal penis area?
So it's very difficult to maintain graft.
But
dressing.
anytime you have to graft, you have to difficult to maintain. I'm
Yes.
asking you the priority. Is the chest area is priority or the genital area is priority?
perineum should be a priority, sir.
Yes. Which area?
Perineum should be because it is also if we leave the raw area there, it has more chances of getting infected again. So
Then if it gets infected, what will happen?
infection from there can go to the bloodstream, causing sepsis, generalized body sepsis.
Apart from that, local, getting it infected, and infection means it will become deeper.
Yes.
And
So-
involvement of urethra
Vital,
can happen.
exposure of vital structures can
Urethra and
store.
Urethra and the
testis, right?
Yes.
So if suppose these testicles are exposed, how will you manage?
We bank them.
We can bank them initially as there is extensive raw
You
area
will bank where?
The medial thigh.
in the middle aspect of the thigh.
Why?
Because there is
Why can't it remain in its place and you can protect it and preserve it?
if it is if there is good granulation tissue over the testis, we can graft for the meantime and let it be there.
In case of exposure, we would want to bank them because they're temperature sensitive structures and they're vital structures that would be exposed to the environment. So we would
Okay.
want to bank them in the medial
So which
thigh.
maintains the temperature normally?
Sir,
What maintains?
that the spermatic plexus, the testicular
Spermatic plexus, other team?
testicular plexus.
What
Uh,
maintains the temperature of the testicles for normal function?
Pampiniform plexus.
Pampiniform plexus.
D.
Right to
Team A
pampiniform
of the
plexus,
T.
we said, sir.
Any muscle?
Cremastric
Cremastric
muscles.
Cremastric muscle.
Yes.
Okay.
Can we give the
Uh,
full marks to them, sir? Team B?
Yes.
Team B, yes.
Okay. Now the
Now,
question
if
to Team A. Team A.
Sir, two questions. Only two
yeah.
questions.
Only two questions. So, suppose on the right side, the wound heals or during healing period, how will you splint and initiate physiotherapy?
Uh, for the upper limb and the axilla, we would like to give an aeroplane splint in position of comfort, which is abduction of
Aeroplane splint where?
bilateral axilla. It should be
Axilla is
contoured.
free. Axilla is free bilaterally.
Okay, on the right. So then, for the lower
You
limbs,
talk of this patient. Don't talk theory. Axilla is free, doesn't require splinting, isn't it?
yes. Sir. So then compression. We would like to do compression dressings with crepe bandage application and
Those things come later. How will you reduce the
accident.
contracture, sequelae? How will you splint and how will you put the patient in position so that there is minimum contracture followed by wound healing?
Not involving. It is involving only the bilateral hip joints only, sir.
So thigh we can splint in the abducted position, sir. Abducted and along with active and passive physiotherapy.
Yeah, 1 mark. So somebody said that it is a deep dermal burn. Would you like to revise it? Looking at the wound? Is it deep dermal burn? See what the wound looks like, how deep it is. You can see the umbilical area, that gives you some idea.
So second degree deep, second degree
superficial and
superficial
deep.
to deep with areas of
See,
deep.
you must ask how many days old this burn is. What is the importance? How many days old?
Because at presentation, depending upon the resuscitation and the further management of the
Suppose you
patient.
see this patient, you will say how many days old.
Yes.
You will ask this question. What is the significance of this question?
Whether the burns have healed, whether it is less than 2 weeks and they have healed spontaneously or not healed spontaneously, what is the time period that has elapsed from the acute setting incident?
Yes. So, if any wound remains after 3 weeks, means it's a deep burn.
Deep burns.
Okay.
Yes.
So, when you are using the term deep dermal burn or superficial burn, you have to be very careful. That's why the mode of injury is so important and the duration of injury, because the wound has matured and there are areas which requires resurfacing. There is no difficulty in that. So these are deep burns. These are not deep second degree. Deep second degree has healed at the periphery, and first degree has healed without scar. That's the correct way of thinking, isn't it? So now you tell me, the grafts which have been put, is it necessary to put it horizontally or vertically? Sheet grafts or mesh graft? What decides? If for wound healing, you can put it anywhere. Let us save the life of the patient. That's a different issue. But scientifically,
Sir, is the question continuous for Team B or is it being
Team B.
passed on to the
Team B.
Team B, please?
Sir, we'll try to orient it along the what we know as the resting skin tension lines or the creases, the flexural creases, so that once it heals, there's no scar breakage further, and it's
Those creases depend upon what? when you
orientation
frown,
of the
orientation of the
collagen fibrils.
when you frown the forehead like me, I'm doing.
Yes.
Then what decides this frowning?
The orientation of the muscle.
The muscle,
Muscles,
Yes, sir.
underlying
Muscle orientation.
muscles.
the
So
direction
which
of the muscle.
which muscle is there on either side of the umbilicus?
Rectus abdominis.
Abdominis.
So how will you put the graft ideally? You can put
Transversely.
anyway the wound heals.
Transversely we'll place, sir.
Why not vertically?
Vertically, it might during the take-up, it might cause breakage in the graft when the patient is moving
It won't
around.
be oriented, huh? Yes.
Yes. Correct.
Marks.
Shall we give 2 marks, sir?
Yes. Yes.
These was those.
What is the
Sir,
drawback of mesh grafting?
So it
Sorry,
goes
sir?
to team A, sir.
no marks for this.
Just general question.
Because equally the questions are given to the both
Both the
teams.
team.
Right. So last question. Anyone asks?
Uh,
Answers.
Sir, what?
What is the drawback of mesh
Whom is the
grafting
question to, sir?
Sir,
No question.
cobblestone
no.
appearance.
The open
Anyone,
question.
vis-a-vis
to
sheet
open
ask.
grafting?
question.
Yes.
Cobblestone appearance.
Mhm. What else?
And
And
risk of contracture, decreased dermal elements.
if,
There are
if it is
reduced.
superficial split thickness grafting, then risk of the contracture is there.
More
And
than
poor
sheet
scarring.
Scarring is
Aesthetically, it is not pleasing.
So against a joint, what will you advise? Sheet or mesh?
Sheet
Sheet
grafting.
grafting.
Sheet grafting.
Yes?
Sheet graft.
Sheet.
Sheet grafting.
Okay. Good.
Now
Thank
we
you.
invite Dr. R.K. Srivastava, sir. To give
It's
your
very
brief.
difficult after Dr. V. Bhattacharya to ask the questions. But still, I
Sir,
have to go first to team 1.
No, sir.
Team A, sir.
Give the
Team A.
summary of management of this
Okay.
quarter.
Okay. So
No questions.
the first picture shows the patient lying with dressing open. So most probably it is acute phase, only few days old or first, second day. He is not even catheterized. And by seeing the picture, it seems that perineal area is somewhat spared, especially the testicles and the penis. But immediately it should have been catheterized, first thing. Second thing, you can see a thin film over the thigh, on right thigh.
Yes, sir. Yes, sir.
So can you assess what is this structure?
That is
What
a
is this
collagen,
thing?
collagen dressing, sir. That is
Collagen
the
sheet.
Collagen sheet.
It may be collagen sheet or it may be amnion even.
Amnion. Yes.
Yeah.
Yes.
Second thing, this may be a thermal burn also, as you told, scald burn. It may be thermal burn, second degree. Okay, for this much child, it is being told that it is 7 years old. So that is quite a lot. You must be knowing rule of 5. And that is applicable up to only 10 years of age. After that, it is taken as adult. Something is deducted, something is added, head and neck and leg and abdomen likewise. So I'm not going into detail because of paucity of the time. The second picture shows that earlier grafting has been attempted. Some areas have taken up, not only on the chest. If you closely see on the thigh also, on lateral side, compared with the first picture, it looks like it has also been grafted and patches have been taken up. And next, again, during the preparation, have been sliced off, wound excision has been done, and now the patient is prepared for the second grafting. Okay. Along with that, the nutrition part has to be taken care of, and the psychological aspect of the patient as well as the family members, especially the parents. Okay. Thank you, madam.
Thank you, sir.
Thank you, sir.
I will move to PG.
I'll PG teams, 2 PG teams.
Yes, ma'am. We have team 6, SMS Jaipur, to team A.
Okay. Question for us.
Can you please tell me a few formulas for calculating body surface area when it comes to resuscitation for pediatric age group?
A group.
London
A.
Browder chart. Yeah.
Resuscitation
No, the
formulas.
formulas for calculating the body surface area.
Body surface area is calculated by London Browder chart. If you're asking about resuscitation, fluid resuscitation, then there.
No, I'm just asking the formulas for calculating the body surface area. Since the standard relationship does not
Methods of
yeah.
TBS, yes,
Calculation.
respect.
The
Maybe
rule
you
of
should pass it to
palm,
the next.
where
team.
palm with adducted fingers is equal to.
And what should be the position of thumb?
Should be adducted, sir.
Hmm.
That will amount to 1%.
Palm of which person?
Palm of the same age.
Of the child himself.
Yeah, that's important.
And it is like
If you can't answer, pass it to team B.
yes.
It goes to team B automatically.
Team
First is the rule of palm, 0.8% at the patient's own palm. Then we can use the rule of 9, which has been modified. We have changed the percentage allotted to the head. It is more percentages allotted to the head. Then one more method is the Lynch rule of 5, which can be applied. Then there is a Lund and Browder chart, which is considered the most accurate. Then there are also now computerized apps and applications which are there, which can be used using specialized softwares, upon which we on putting the photographs, they will calculate as per the age and the weight accurately.
What is the score that we have to give? Is the answer right?
Ma'am, we can give 1 mark to the second team.
Okay.
What you want to supplement? One more.
Ma'am, actually, I wanted to know the formulas for calculating the body surface area, which is in the pediatric patients. We have a normogram since we don't follow the standard relationship which is there in the adults. So
Yes.
we have two formulas named with Du Bois formula and Jacobson's formula for calculating the body surface area, using which we basically give the resuscitating fluid to the pediatric patients. So I just wanted to.
What are those two formulas?
Ma'am,
Elaborate.
so the Du Bois formula, Jacobson's formula, by Jacobson's formula, we can calculate the body surface area as height in centimeters plus weight in kgs minus 60, the whole divided by 100. And we have a Du Bois formula in which we calculate the body surface area as height in centimeter, which is to the power of 0.725, into weight in kg to the power of 0.425 into 0.007. So these are the methods to calculate the body surface area. And
is it clinically
No,
applicable?
how
Is it
to
applicable?
apply this for percentage of burns?
No. Is it applicable and
sorry, ma'am?
Actually, these are body surface area calculation formulas, not the burn surface area.
Percentage of burn,
body
how can
surface
it be
area.
calculated by
yeah,
them?
burn surface area only? Is it
Your question
practically
was wrong.
applicable?
So
Ma'am, it
I
is
think,
for body surface area calculation, not for burn surface area calculation. We can either use nomogram, which is
Body surface area calculation.
yes,
Ask the
not for
question
the
for
burn
body
surface.
surface area calculation.
That question is, their concept of question was wrong. The question should be how to calculate percentage of burn in children.
Yeah,
Those
that's what.
different
Using body
formulas.
surface area.
No, sir, I
So
think
the team has asked wrong question.
Yes.
With wrong
sir, no, I
concept,
think,
you can say.
No.
So I want to just intervene.
Yeah.
I think they have a point here because a lot of the pediatric departments feel that we need to look at the surface area of the child rather than the percentage of burn.
Yes.
So I think they have a point here. Some of the resuscitations that we do take into account the body surface area, which is calculated by the normogram or one of these formulae. And so it's per meter square that you give the fluid resuscitation. So for instance, I think what is recommended is about 1500 ml per meter square.
Okay.
So
But
that
sir,
you'll get
then
only
it
from
will
these.
be over calculation. As we follow the
Correct,
percentage
correct,
of burn,
correct.
it will be over calculated.
Overcalculated.
And we are
Correct.
over hydrating the
Children.
child, which is much
Correct.
more
More
dangerous than
dangerous.
calculating less.
Correct, correct. So which is why they use the body surface area calculation,
Yes,
and it per
that
square
for-
meter fluid resuscitation is on
For
per
body
square
surface
meter.
area, it's okay.
Actually,
Correct.
there are standard tables to calculate the body
nomogram,
surface
yeah.
area. So
Yeah, yeah.
that is a very easy method than this. Okay. Right. Next team, please.
Team 9.
I think
Southeastern
can
Railway.
cancel that question.
Okay.
Nobody will get any
Okay.
marks. Yeah.
Sorry.
Okay, ma'am. Now, Team 9, Southeastern Railway to Team B. I will ask next team to Team A. ma'am.
Will we get a question in addition because that question was cancelled?
We'll give you option. Let
Yeah, my
Team 9
question
to
is,
Team B.
what will be the difference in outcome if we are giving an allograft from the cadaver and an allograft from the related donor like parent?
What is the question?
Could you repeat?
What will be the difference in outcome if we give an allograft from cadaver versus an allograft from the parents, related donor?
Allografts are generally given in the initial stages to prevent evaporative losses since they are higher in pediatric age group. An allograft from a related person, like the mother or the parent, is obviously going to be better. And sometimes they might provide cover for a longer period of time and then can be autografted later.
And what is the timing of rejection in both the cases?
Approximately 3 weeks.
Starts rejection in a cadaveric allograft
Is
can
earlier.
start from 10 days up till 30 days. From if an allograft is taken from a relative, it will be much later.
Yeah, okay.
So
Now,
shall we
Two
give the
marks.
full marks?
2 marks. Yeah.
Yeah.
Now, Team 10 to Team A. BMCRI. PG is from BMCRI.
Yeah, apart from that allograft, what are the other temporary wound covers for this patient?
Team A.
Apart from what?
Allograft.
Allograft.
Yeah.
What are the other
Then-
covering material?
Temporary wound covers.
Like biological dressing like amniotic membrane, then collagen dressing, and silver-based dressing like Acticoat and Ergotul. Then we can also use the dermal and epidermal component containing dressing like Integra and BioBrain Duodum.
Anything else?
Hydrocolloid foam dressings.
Team B, if you want to add, you can add.
We can also, for very extensive areas where we don't have the availability of, if skin substitute we are not using, we can also use xenografts.
Yes. Yes, like a team was the second team added one more point, and most of the answer was given by the first teams.
So
Two
can we give
marks
full
to
marks
the-
to Team A?
Yes, ma'am.
Okay.
Ma'am is
Now the patron question, Dr. SP Bajaj sir, I invite you to ask few questions. Bajaj sir? Sir is there? Okay.
We'll ask other panelists or anything.
Any other panelists?
Dr. Bajaj is there.
Sir, please unmute.
Sir, unmute, sir.
He is there.
Any other panelists or moderator,
Sir,
faculty?
Dr. Bajaj, sir, please unmute. Unmute yourself. His speaker is not on.
I'm sending request also, sir, to unmute himself, but sir has to do from his end.
Sir, we'll proceed, sir.
So can I have a question, ma'am?
Yes, sir. Yes, sir. Sir Chaudhary, sir.
Okay. So I think the panelists have asked very nice questions and almost covering almost all aspects in these cases. So some panelists have already asked a question. I just to continue that. In a perichondritis of the ear or pinna, what is the commonest symptom the patient presents with and complains?
Team A.
Team
Pain.
A.
Patient has severe pain.
Okay, fine. Then how do you manage that case?
Um, moist exposure dressings, and if the
No,
cartilage is
patient
exposed,
has come with perichondritis with abscess.
We drain.
It looks like an
First of
abscess.
all, drain.
How will you?
First of all, we will treat symptomatically with painkillers and proper
Drain the-
I told
antibiotics.
there is collection.
drain the abscess,
How?
giving an incision at the rim.
Yeah.
So you get half marks. Let this second team answer it. Team B.
Nick, if there's a collection or an abscess, an incision or drainage can be done, and then contour dressing can be done for the ear.
How do you do the
How will you
incision?
drain?
How will drain it?
From posteriorly.
Posteriorly,
So
and
can I
need to
answer?
have
No. Team A already answered.
Already
That is
you have
correct.
lost your chance. Team B.
Posteriorly, we have to give cruciate incision.
How to give an incision?
We can give a cruciate
Minus,
incision.
plus, minus or plus?
Sir, Team A
Cruciate
answered,
incision.
sir. How to
Okay.
drain also
Okay.
they
Thank you. Thank
answered.
you. Okay. My next question will be, suppose in this case, you are given a choice, a meat graft or a stamp graft. Which will be better?
Team B. Team B.
Team B.
Sir,
You get the graft from the
paucity
donor
of
area, from the back.
As
What
there is
is the
extensive
preference? You give one answer.
Preference, I
E-graft
am not
or
asking.
stamp?
meat grafting, ma'am, because there's a paucity of donor area, so we can cover a larger area using a smaller limited amount of donor skin. Meat grafting can give a
Correct.
more expansion.
expansion of
Correct.
approximately
Correct.
Okay, done.
So full marks.
Madam, that's
Full
it. Thank
marks.
you very much.
Okay.
Dr. Bajaj is
The
on.
Bajaj sir
So-
is there. So, sir, Bajaj sir,
Anji beta.
would you like to ask one question or want to contribute something, sir?
No, they are doing very well. The
Yes,
only
yes.
question which I am going to ask, granulation tissue which you are seeing on the abdomen and chest, what they denote?
Team A.
Team A.
So can you repeat the question once, sir? We did not get.
You are seeing granulation tissue
Yes,
on
sir.
the abdomen and
Yes, sir.
chest. Is this what this type of granulation tissue is there? Are you worried for the granulation tissue, or you are quite happy with it?
Yes, sir. If it is red healthy granulation tissue, it is like normal healthy granulation tissue. But if it is red friable granulation tissue, it is because of the staphylococcal or streptococcal infection.
I am just asking, beta.
Is
If
this healthy or not?
data is not there, now this patient is there, you are seeing the granulation tissue. What is your perception about this? Are you happy or unhappy?
Yes, sir.
With this granulation
It
tissue,
looks
I'm
like
worried
healthy
that this
granulation
patient may
tissue.
die in a day. With this granulation tissue, I think this patient may die in a day. Am I fool in thinking so?
Team B, can you answer?
Team B is looking angry, looking hypergranulation tissue.
Because you just see all around the situation, you're seeing granulation tissue which is unhealthy. And this is involving practically whole of the chest and abdomen in a child of 7 years of age. So this is quite an indicator. There's a serious matter going on. Now, if you just see this thing, if you cannot say this is a serious matter, then probably you need to learn more about seeing the patients. Now, such patients you see around, they are very sick patients. They're not ordinary patients that you put it down something and they'll settle down.
Infection.
So therefore, if you just see, if you normally see all these patients, if the granulation tissue is healthy, you will see surrounding skin is quite pink around, and there is no edging is there around as eaten up appearance of the edges. You are seeing eaten up appearance of the edges, which denotes something grossly serious going on. These patients are now become immunocompromised. They need to put it down on some situation so that things become better for them. I'm so surprised. So many questions are asked and not a single one. You see it here. Now see on the right shoulder. Same on the right shoulder. You see on the thighs. You see on the suprapubic area. Now, all these things denote that there is something grossly going down. The very severely infected areas are around. Intimated granulation tissue is a direct indicator that these areas are having some dead tissue around. And what dead material is? The bacteria and other situations are there. And this is a fundamental requirement for a person who manages the burn to immediately see yes, there is some serious thing going on. You can't simply go and put down graft or other thing. Now, you have failed to give the answer to this question. Now, I have given what the problem. What investigation you like to do and how you would like to manage this case.
Team B. Question is to Team B.
We'd like to send, since this is looking
The same team is going on.
Team B is
Team B.
Now, I have not passed this question to Team B. I just remain there and I have given second question asked to the same team. So therefore, no Team B question.
Okay, sir, sure.
Yes. So we would like to send pan culture, sir, because the patient is catheterized with indwelling catheter, blood cultures, urine culture, and tissue culture from the flexural areas where some amount of slough is seen. And we would like to send CBC to check for the counts and Procal to look for sepsis and CRPH.
Normal blood investigations.
PTINR to assess the.
Tell me, what is the count when the wound is there, what you get worried about?
What is the count?
Wound count.
Wound count.
What it is called?
It is either it is leukopenia or leukocytosis. Both are
No.
Leukopenia and counts less than 3,000.
No, Raja, but I didn't ask you this.
10 raised to more than 10 raised to 5
I
organisms.
asked you the question, what is the bacterial wound count?
More than 10
to the power of
10.
5.
Yes, 10 is to power 5 microorganism per gram of tissue.
10 is power 9. Okay. Anyway, that's good. So therefore, that denotes that these patients are going into the severe septicemic phases. And therefore, you have to think in those terms. Okay, so you have answered one question correctly, so therefore you get 1 mark. Team B. Team B, can I ask question?
Yes, sir.
Now the same patient which you are seeing down there, how you will prevent infection going from one point to other in this patient?
Sir, could you repeat, sir?
Now you have seen this patient. Now there are infected areas there. What is the mechanism by which you would like to prevent the spread of infection from one point to another point?
Separate dressings over each region, sir. Like thigh will be.
We would try to prevent infections that are transferred through fomites. So therefore, hand hygiene would be encouraged during dressings.
Very good.
all separate units shall be dressed separately and gloves shall be changed in between. Separate cultures will be sent from different regions of the.
How you can put down the separate dressing in these cases? There are all contiguous parts are there. How you can put down separate dressing?
Sir, could you repeat, sir?
How you can put separate dressings? These are a
You
continuous.
can put down separate dressing. It's a continuous areas.
So I meant a thigh. Both the thighs would not would have a separate dressing than compared to the trunk.
एक थाई तो दूसरी थाई सेपरेट ही रहेंगी बेटा. दोनों थाई इकट्ठी तो नहीं करोगे ना.
We'll time them.
Now, in those areas which are the groin area and other area which are seeing it around, you put it down something in between. So groin is the most infected area because of the flexure of the pointer. So therefore, you put down some specific antibacterial creams in between so that they are separating it out. And then you do the dressings. Is it clear? Okay. So you are also given one answer correctly. So therefore, you half answer correctly. So you will get 1 mark. But
Thank you, sir.
Thank you,
Thank
Beta.
you, sir. Thank you.
Thank you.
Now we'll move to the third spotter. I invite Dr. Ravikumar Chitoria, sir, from Jipmar Pondicherry as a panelist, and Dr. Malti Gupta ma'am as a moderator, and Dr. Angeline Selvaras madam and Dr. Sanjeev Uppal sir as judges to discuss the case. Dr. Ravikumar Chitoria, sir.
Good evening all. Good evening all of my senior teachers and all the students. And so there is a photograph here kept. So please, whichever team is starting, team A or B.
Team A, sir.
Okay, team A. The first question is, please describe the findings.
So we can see this is a healed burn with a patch of grafting seen on the chest, extending meshed skin graft, split thickness skin graft from in the region of left hemithorax, left hemi-abdomen, and there is a flap. It looks like a myocutaneous flap around the umbilical region, and there is hypertrophic scarring at the lower and near the abdominal region with hyperpigmentation, and patches of depigmentation in the upper thoracic region and on the arms, left arm and forearm.
Okay, same question is asked to group team B. If anything, would you like to add?
Team B.
Yes, ma'am. This is a healed burns.
No, other than what team A has already told, please, would you like to add?
Anything you'd want to differ or tell?
This hypertrophic scarring around the umbilicus leading to its distortion.
Do you agree with the team A or differ or supplement?
Don't think this is a.
Don't go with their answer. You tell anything differential diagnosis.
Yes.
If not, sir, go ahead with the second question.
Okay,
So
then
can we give
marks,
full marks to
One mark. Or
1 marks to 1 marks to team A, no mark
Okay.
to team B.
Okay, sir.
Okay, second question.
To
As you
team B.
said,
Team B.
as you said, team B, please listen. Now, after the describing the findings, if this patient comes to you, suppose this patient is got electrical burn injuries with the component of thermal injuries also. So if this is a electrical burn patient, what do you think in emergency complication you would see? Acute complications.
In case of electrical burn, sir, if this patient had presented to us in the acute setting, we would want cardiac monitoring for at least 48 hours.
No, no,
Resuscitation.
no. Please listen. We are not
Yes,
asking you how you will manage or monitor. I am asking you what it will come in your mind. You are in casualty. You have been called. This patient has got electrical burn. Okay, now this patient has survived and healed. Think this patient has come in the casualty and it is an electrical burn of which region? Abdominal region. So here today we are discussing in a abdominal electrical burn case, what
Any,
will come in your mind?
there can be any
Acute,
breach up till the peritoneum.
You anticipate what is there, what can be there. That's your answer.
See, what the
What do you
mind knows,
expect?
your eyes will see. So what will come in your mind? There is a electrical burn of abdomen.
So if it will be deeper involvement, so we will see suspect there can be a breach in the peritoneum
or the
or
anterior abdominal
the
wall,
anterior abdominal wall,
which can now present as
Not now. There at the acute stage, sir is asking.
breach in the anterior.
Don't imagine the patient survived.
Think this patient is in the casualty. There is a acute electrical burn involving basically the abdomen area with some flash thermal burns here and there over the upper limb and the chest. But I am asking you, which immediately will come in your mind? Acute
abdominal compartment
complications.
syndrome.
Very good. Very good. Number one. Any
What
other?
other?
Should I ask team B, sir, madam?
Team A now.
Team A, ma'am. Team A, sir.
No.
So they can.
Tell team.
Pass
team
it on to team A.
Okay, pass on to next team.
There can be bowel ischemia leading to bowel gangrene.
Very good.
Very good.
Very good. So one is team A said yes, there is a possibility of injury and there will be a perforation, there will be a gangrene. Then any other thing? Both team, or should I pass to the previous team? Acute emergency where immediately something has to be done.
Eccentric ischemia.
So you feel that is a high voltage burn starting from skin to all the viscera. So first is the patient immediately will go into gangrene. Gangrene possibility is there or not? So that ischemia is okay. But for ischemia you can wait. But I ask you the acute complication where you would like to immediately operate. So patient will develop gangrene.
Gangrene and perforation.
Okay, so for this question, madam, you can give 1 marks to both the team.
Okay, sir.
Okay. Now, as you said that there is a possibility of compartment syndrome. Why patient should develop compartment syndrome in abdominal electrical burn?
Team A.
Because although the skin is not circumferentially involved, but in the compartment, the peritoneum is a closed sac, and the electric current passes through the area of least resistance, and so there will be more internal injury than what is seen externally, leading to bowel edema and increase in the intra-abdominal fluid, intraperitoneal.
Okay, so something you have answered. Now, same question to other team.
Team B.
In case of electrical burn injury where the depth is higher, there can be an unyielding leathery eschar formation, which will lead to, even though it is not circumferential, which when combined with the edema that will set in inside and will lead to raising of the abdominal compartment pressure, which can lead to the abdominal compartment syndrome.
Okay, what is the name given to that kind of edema? Both the team. Till now, 1 mark is given. What is the name given to that kind of edema?
Fluid creeps.
That is the mechanism.
Interstitial
Splanchnic edema. So what we call it? Splanchnic edema. Correct? And what is now again Next
Team
question,
B.
madam. Next
Team
question.
B.
Next question. So 2 questions are over. Marks are equally given 1-1 to both, madam.
Okay. Now
Next
go to
question
Team
is,
B, sir.
so since we were talking about the one mechanism, as you said, is the increase in the intra-abdominal pressure and also the direct injury to the ischemia causing the thickness and thick scar causing the compartment. What is the other mechanism? Do you know IV index? Team, first team, IV index.
IV
E
index.
IVY. Yeah,
Yes.
IVY. What
IV
is
index
IV
is the
index?
threshold is the index which calculates the threshold of fluid resuscitation per kg weight, body weight, which is 250 ml. In case of fluid resuscitation, which is more than 250 ml per kg body weight, third spacing increases and the chances of abdominal compartment syndrome or pulmonary edema are increase.
Okay. So it means, as you said, this IV index is more applicable for abdominal burns, especially the electrical burn. That is why one should be very careful
Yes, sir.
that in per kg, not more than 25 to 50 100 ml or at least 16 liter in 12 hours in an adult patient. So
Yes,
that
sir.
is why we should be very careful, and invariably it is not the injury actually, it is the fluid itself can cause the problem, and you will end up with the increase in the abdominal pressure, and then you have to open. Okay, now next
So full
question
marks
to,
to, sir, full marks to Team B.
yes.
Okay, sir. Now the question to Team A.
Okay, so next question is, what is the mechanism of electrical burn?
So
Suppose in
there
the abdomen current. Yes, yes. Speak.
are two theories for electrical burn. One is the Joule's theory, where intensity of burn is directly proportional to current square into resistance. And another theory is the volume conductor theory, where it depends on the because the trunk has more circumference, the heat dissipates from the trunk faster, and then lower the circumference around the digits, there is more risk of burn. And the electroporation theory, these are the three theories, sir. And the pathophysiology for bowel injury could be due to microthrombi that occur in the in the mesenteric vessels, which leads to bowel ischemia. And
Okay, so you have answered something, and some of the mechanism you have explained. So team B, another next team, would you like to add something more?
But in case of electrical burn injury,
As she said, Joule's law,
Yes,
not
sir.
Joule's theory, it is a Joule's law.
Law.
So something she said formula, was it right or wrong?
P
Did
is
you?
equal to I square R, sir, is the joules
Power is equal to square of the current
into the
into the
resistance.
resistance. And
And
then
no
there is,
time, no
sir,
time. Time will you not multiply by time?
I square R.
Time. How long it will occur? That is how the more time the, isn't it? So
Electrical current passes,
more
the more
that is
the
why.
injury.
So there are two law. I should not give answer, but I
other
am
is
telling
the
you. Other law is?
other law is the Ohm's law.
Ohm's law. So what is Ohm's law? She said, and would you like to?
Ohm's law states current is equivalent to the voltage divided by the resistance.
Okay, madam, both can be given 1 mark. Next question I will ask.
Okay, sir.
So, okay, this patient has survived, and as you said, on the abdomen, some bulge is seen. So, whichever team has to answer, what is the differential diagnosis of this bulge?
Can be a ventral hernia, sir.
Number 1, yes. Next.
Can be a ventral hernia, and it is in the surrounding normal skin below the normal skin. So tissue expander.
Should I ask the next team, or would you like to give more differential diagnosis? If you are over, then I will ask other team.
Hypertrophic scarring in the surrounding of the
No.
lesion.
I'm not asking the. I am asking about the differential diagnosis on the right side of the abdomen, lower quadrant. Can you see something circular?
Yes, sir.
Yes. So please, I am asking you by photographs, but just by seeing it, you have not examined, you have not taken history. Only thing hint is that yes, such much deep burns are possible only in electrical burns. So we started with the electrical burn. Okay. So I'm asking you, if you are completed your answer, should I go to the next team to add on if they want to add on?
So how many marks, sir?
Ventral hernia.
No.
along
First let the other team also decide answer if they are
Okay.
not.
Yes,
this is a
so differential, it could be ventral hernia or it could be a flap that has been done to cover the exposed bowel or something.
Okay.
It could be local flap or reflap.
Okay, so three things, two you have added, one they have also added. They said hernia, and you said there is a possibility of some reconstruction done, so it's like a flap that can be a whichever the flap was done by that surgeon. And then in between, some of you said expander also. Okay, madam, one marks can be given to both.
Okay, sir.
Okay. Now next question to the
Team A.
Team A. So if you have to reconstruct the abdominal wall, tell me the layers of abdominal wall, anterior abdominal wall.
Skin subcutaneous tissue, which can be scarpa fascia and Camper's fascia. Then anterior rectus sheath, which has 3 layers, and then the rectus muscle, peritoneum, and preperitoneal flat followed by peritoneum.
Okay, madam, 2 marks to this team. Next question I
Okay.
will ask.
To Team B.
Okay. So now since you were planning of doing the reconstruction, patient has survived. Otherwise also suppose this patient would have survived and this is a male patient, but suppose this patient is a female patient. What do you think the problem will be there in long run for a female patient?
There will be problems in her pregnancy, and there will be absence in the left breast. So we'll have to reconstruct the breast and strengthen the abdominal wall so that when she is pregnant, she can successfully continue with her pregnancy.
Okay, so one problem you have highlighted is, yes, when she will become pregnant, in case the patient is female, and if she becomes pregnant, there is a possibility of now risk to the baby because you are not allowing the expansion of the anterior abdominal wall. But now you have decided, okay, there is a problem to the child also and the mother also. Okay, this is one problem. Any other problem, or should I ask the other team if they want to add?
The breast, here we can see the nipoareolar complex has completely been
Okay, let us talk about the abdomen only. Okay, in the abdomen, now you have a problem, and now you have decided that I must give a release. Why? Because it is not expanding. Up to 3 months, she could bear the pregnancy, and now after 3 months, she is not able to. And when the ultrasound is done, baby is at risk now. Baby is not growing. IUGR is developing. So what I'm saying is there any risk now when you release? Next team, other team.
Team A.
There will be rectus sheath diastasis and
No. Okay, so madam, should I give the answer or?
Yeah, sir, give the answer and tell us how much we should give the marks.
Marks will be given 1 mark to the first team and no marks to the other team. They could not answer.
Okay, sir.
Okay, so the problem is when you release, there will be what problem? There was a before release also problem, and now there will be problem at the release, not anatomically. There will be sudden fall in the abdominal pressure. And now when you release, what will you, when there is a sudden fall in the pressure in abdomen, what happens? There will be a risk to the baby. Suddenly baby will become at risk, and of course the mother may be survived, baby will fall. So when you are releasing a pregnant patient with abdominal wall constricted, it has to be done very carefully and in a very slowly with monitoring going on. So preferably if there is a abdominal wall pressure monitoring possible, because the devices are available. So these are the problem which I ask. Should I ask the next question, madam?
Yes, sir.
Okay. Which team, madam?
Team A, sir. Team A.
Team A. Tell me the Hughes zones of abdominal wall.
There are three zones, zone 1, 2, 3, from the umbilicus. It is a, no, from the central, from xiphisternum to umbilicus, and from umbilicus to lateral abdominal wall.
And then below the umbilical.
The total three zones, the center of the umbilicus and the surrounding part is the zone 1, and the medial one is the zone 2. And
Sir, the central zone extends from it's around the in paraumbilical region till the semilunar lines on either side. And the zone 2s are beyond the semilunar lines to the lateral anterior axillary port, anterior axillary line. And the zone 3 is below the umbilicus till the pelvic pubic crease.
Okay. If you have completed, should I ask the other team to modify or other team? Do you agree?
Team B.
Team B?
Team B.
So from the over the suprapubic on either sides it will be zone 3, and over the suprapubic region will be zone 2, and from xiphisternum till the umbilicus will be the zone 1.
Okay. So both were describing the zone, but the numberification little bit did wrong by the team 1. So actually zone 2 is below the umbilicus,
Below the
suprapubic
umbilicus.
area. That is what. Otherwise, when the description was going on, so I would give 1 marks to both the team, madam.
Okay, sir.
And next question is this zones.
Team
What
B.
Team B?
Team B.
What is the basis of this zone?
Sir, based on the blood supply in the abdomen, sir, the superior mesenteric artery, the inferior mesenteric artery, and the
No, I am not asking you all the arteries of the abdomen. I am asking you basis. Basis being zone 1 which supplied by which artery, zone 2 is supplied by which artery, zone 3. Because why it is important? In case you have to use later on for reconstruction, vessel is our most important concern, always. Blood and beauty. So blood supply we want to know. Because that planning of the reconstruction will be accordingly. So zone 1 is supplied by what?
superior mesenteric.
Should I ask the other? No. You once you complete, then you please clear that I have completed. So I will.
Inferior epigastric.
Is there any time limit for them to answer, or they will keep thinking?
Sir, if you feel it can pass on, sir. There is no
Pass on. Pass on. Pass on to other team. Please tell me the zones, Hughes zones.
Sir, the Hughes zones are based on the vascular supply of the abdominal
No,
wall.
don't repeat
So,
that. Tell me zone 1 is supplied by which vessel, zone 2 is
zone
which
1 is supplied by superior epigastric artery, sir, and zone 2 is supplied by the inferior epigastric artery, and the zone 3, which is on the lateral sides, is by the intercostal perforator.
Okay, madam, 1 marks to this team and 0.5 marks to the other team.
No 0.5, sir. Either they get it or no more. No
Okay,
marks.
then this team gets the 1 mark at
1
least.
mark.
Other team
They
no mark. No
doesn't
mark.
get mark. Okay.
Should I ask the next
So
question?
timing, sir. Time is over or still there?
No.
1 minute more.
1 minute more. Okay. So tell me the Matthews classification of abdominal wall defects. Whichever team has to answer.
Team A now.
Matthews classification.
Okay,
Yes.
over to next team. Next team.
Team B. Sir, you give the answer, sir.
Okay, the Matthews has classified the abdominal wall defect into 3 types: type 1, 2, and 3. And it is basically anatomically. Type 1 means myofascial layer alone. And type 2 means myofascial layer with skin loss also. And type 3 is skin defects alone with the preservation of myofascial area. So you must have seen like any post-burn raw area over the abdomen, everything is preserved, only skin is lost. So that comes under type 3. But when it is a myofascial layer with the skin loss, it is type 2. And internally only myofascial skin alone. Why it is? Because that will decide your depth of the reconstruction, and planning is also done accordingly. So each defect type 1, 2, 3 is further divided into A and B. And why is considering this A and B? Taking into consideration the again blood supply. Laterally he is divided na, the Hughes lateral area is B and the midline or the central area is A. So my next question, because 30
So
seconds are
team B, sir.
team B. Now
Team B.
can you based on this understanding of blood supply and the defects layer, can you divide the methods of reconstruction? Techniques of, can you tell me the classification of closure techniques more specifically? Over to next team.
Team A.
Okay, so madam, answer is the techniques are divided into displacement technique or replacement technique. So displacement technique means you are displacing the, not replacing, you are not bringing any flap, you are displacing whatever is existing. So that is comes under the technique called CST, component separation technique, which can be with or without prosthesis. Prosthesis can be mesh or it can be acellular dermis, which is available nowadays. With this, madam, my time is over.
Yes,
Okay,
sir.
sir.
Thank you, sir.
Thank you.
Madam Dr. Malti Gupta, ma'am, I invite you to ask questions for 5 minutes.
I think I've been a student all this while listening to all of these people asking questions and the team giving answers. I've learned a lot today. But anyway, I'll ask some basic questions. Which team, I don't know.
Ma'am.
Is it the
Team
whole of
A.
it is electric burns? The whole of it is electric burns, or there is some other component also?
Ma'am, electric burn, and there is also a thermal burn component due to the flash burns. So the burns on the hand could be due to the on upper limb, that is forearm, arm, and forearm could be due to flash burns, and in the upper chest region.
Okay, yeah. Now the question is to next team or?
The team B.
Madam, can we give full marks to them?
Yeah, please.
Okay.
Always when you have electric burns, there is a wound of exit and a wound of entry. Can you identify here something like that?
The infraumbilical region where we've seen can be the contact area or the wound of entry.
How do you say that?
The depth of the burns is maximum there because there is some anterior abdominal wall weakness due to the excision that was carried out later.
Team A, would you like to say anything?
Entry wound could be on the abdominal wall, ma'am, as
No. Yeah, even I can't see any exit point here. Anybody can tell me? Anybody from the faculty?
What?
The exit will
About-
be somewhere at a distance, either from the scalp or from the lower limb near the sole, and that picture is not shown here.
Yes, yes.
So it is,
There are
we
other
cannot
pictures,
comment upon the exit.
Ma'am, we are
So
going
we-
to show all the details of this case.
Okay. What is the profession of this person? What do you think? How, or maybe how did he get this?
Madam, can we give full marks to the team B?
Yeah, please.
Okay.
could be an electrical lineman working at heights with on the poles closer to dealing with electricity. And he looks like a young, middle-aged, a young male. So probably he would be an electrician or an electrical lineman. And this could be an occupational hazard which he had encountered at work.
Mhm. So I think what are the other mechanisms by which normally you see high tension electrical injuries in general, and particularly on certain occasions? Can I ask the other team or should I?
Other team.
Which team?
Team B, ma'am. Team B.
Team B?
Yes, ma'am. Second question to team B.
What are the other mechanisms which you normally see in high tension electrical injuries? He's supposed to be an electrician or working with the electricity board. But what are the other common mechanisms that you come
In
across?
case of on construction sites, if there are any live wires exposed, that
Yeah.
could lead to electrical high tension, high voltage injuries.
Or he can
Any
be,
other?
or he can be a farmer working in a field where lightning has struck.
Yeah.
Transformer bursts, especially in rainy seasons, can be a source of high voltage.
Which one? I couldn't hear. What did you say?
Transformer explosions, ma'am.
Okay, transform. Yeah. Can I pass on the question to team A?
Yes, ma'am.
A mechanism of burn, electric burn in general, in pediatric age group, it could be due to
High tension electric injuries we are talking of.
only high tension. So it could be
Yeah.
kite while in children trying to fly kites that getting entangled in high tension wires, and there
Yeah.
can be arc burns when a person passes close to high voltage lines because
Yeah.
of ionized and
Terrace and
fall from height of terrace. nahin.
a line passing over the terrace. So while
Close to the
climbing or
Yeah.
while inadvertent contact with the tree, line passing over the trees.
Yeah. So I think both the teams get 1 mark each.
Okay, madam.
Do you know
Ma'am,
for
time is over, ma'am.
okay, right. Fine, thank you.
Thank you, ma'am. Now I invite the judges, Dr. Angeline Selvaraj, ma'am, and Dr. Sanjeev Uppal, sir, to give a gist of this case.
Yeah, fine. So the case as such presented is not a very usual happening, and maybe sometimes such cases come. We have also treated such cases with expanders and flaps. So the abdominal burns, the electrical burns mainly, as already described, can be due to the high tension or low tension current, and both have their own damages occurring. The initial damage, the whole situation, as we see in burns, one is the part on the skin, which we exactly see on the admission. The rest of the things in such burns, abdominal burns, we need to wait for some time. And sometimes in a day, 2 days, or 3 days, the abdominal organs dysfunction or abdominal pressure increasing and then causing this damage. So that would be evident. So patient has to be in the ICU situations, and it has to be a multidisciplinary team. This kind of case should not be handled only by plastic surgeons. So the residents must remember that they should involve the general surgeons, the radio diagnostics people, and of course intensivists. So there's a team approach which goes to treat such a case, and it's very difficult to save such a case. After the savior, once you see sometimes there's only the case which we treated was a lady. She had fully abdominal wall gone, and initially it was the skin graft only was given, and luckily she survived and graft was taken up. So later on the defect was there where the intestines were bulging out on the lower abdomen. So we did cover it. So sometimes the situation is such that the patient has to be very, very careful in the future also till a definite flap or other coverage is done. Regarding something special in this is the mode of injury, which I think Dr. Malti, our respected Dr. Malti, has thrown a light on about shows us a lot of preventive aspects also. Which children must be educated not to go on the roof near the high tension wires and fly kites. And even after construction, sometimes some iron rods or something pipes are kept on the roof. So the children they go there and they are unaware that a line is passing by, and they entangle that rod or the kind of things into the high tension wire. So the strength of current also varies. As Dr. Chitoria has very nicely asked and briefed also, that it matters how much is the strength of the current, how much was the current, the time period of contact, and what is the kind of the resistance, as we know in the abdominal structures, would be very that way, not very high as in the bones and all. So the burns, direct contact burns would be there on the abdominal wall. And many times there is an exit and entry points which you can make out. But that finally, I think from the treatment point of view, exactly it doesn't matter the entry or exit point. And so the rest of the treatment goes like the burns as such. So the crux of the thing is that it has to be a multidisciplinary team treating such burns. And if we can make such patients survive, this is of course a very good thing on the part of the plastic surgeons. So that is how my deliberation goes on this case.
Thank you, sir.
Ma'am.
Ma'am, Dr. Angelina,
Can I add one point if you don't
Sure.
mind?
Yes, please, madam. Yes, please.
Yeah,
Yes,
the point of handling the kites which are entangled in the trees or in the wires. How do you handle them? Normally, we use wooden bamboos sticks, and most of the time these bamboo sticks are wet. So when we are using those wet bamboo sticks, the current passes through, and then we get those high tension electric burns. So what I had suggested sometime many years ago, that we can when we are selling kites, we should also sell along with that fiberglass sticks, and teach the people that when they want to sort of loot a kite, loot a kite. I don't know what's the English word for it. So when you want to loot a kite, then you can use that fiberglass bamboo instead of a wet or a wooden bamboo stick. So I think that's a point you can make a note of it and maybe tell the government or people about it.
very
Thank you.
nice point, ma'am. Angelina ma'am.
As far as I'm concerned, almost all the points regarding the management has been dealt. Only one thing I wanted to highlight is regarding the full thickness loss of a portion of the abdominal wall that needs reconstruction in the immediate phase. That has to be planned. For example, here almost what is the domain that is lost? The abdominal domain and the limitation of the reconstruction that has to be done. Here, almost 1/4 of the lower abdomen, full thickness defect will be there. And that includes exposure of the bowel, peritoneum, and omentum, which may be coming out. So in that case, you may have to have a reconstruction for the inner lining, that is the peritoneal closure, which may require a synthetic or biological mesh, so there are different types of mesh that can be used. Synthetic mesh, biological mesh, and biosynthetic mesh. So there are different types like polypropylene, that is polytetrafluorine mesh, and biosynthetic meshes which can be kept over the peritoneum, over which a flap cover can be done. Here, a tensor fasciae lata or a pedicle anterolateral thigh flap can be used to reconstruct the anterior abdominal wall. So only that point I wanted to highlight before I close this session. Thank you.
Thank you, ma'am.
Thank you, ma'am. Now we completed the
Teams. Two questions.
PG teams.
2 questions, ma'am. Team 11 to Team A. Team 11. PG is from KEM Mumbai.
Hello.
Yes.
Hello.
You are audible.
Yeah, ask.
You can ask question.
What are the components of Vancouver scar scale?
Vancouver scar scale has there'll be a color, thickness of the scar, and texture,
Liability. And pigmentation, color.
We started with pigmentation. 4, no? 4 are there.
Four.
Pigmentation, texture, yeah.
They have missed one.
You can add.
Height will be has to be also there.
Thickness, we had told thickness.
Sure.
Elevation, or it's an actual elevation.
Height or thickness.
Can we give the marks to Team A?
Yes, ma'am.
Okay.
Okay.
Now Team 12.
One question to Team B.
Team B from Team 12. Team 12. PG is from Bhopal.
No questions, ma'am.
No questions. Yeah.
So one question has to be asked to Team B.
Team 5, Jipmer is here.
Yes, sir.
You can ask one.
You can ask one question.
There are no questions.
Okay, so then finally I'll ask one question to Team B. If you are going to place a mesh for reconstruction, what are the positions of mesh placement? What are the ways a mesh can be placed in an anterior abdominal wall?
So ma'am, it can be an onlay mesh. It can be a pre-peritoneal mesh first, then can be onlay mesh, inlay mesh.
Okay.
Or recto-rectish placement, and it can be a pre-peritoneal placement.
Yeah, you have said all the 4. Yes, onlay, inlay, sublay, and hypo. Yes, right. You are right. I give you 2 marks. Okay. I think we have equally free.
Can I ask one question, madam?
Yeah.
So if you are asking 2 questions, sir, 1 to each team.
Both team I have to ask one.
Yes, sir. Yes.
Okay. Very fancy, na? Nowadays, mash, PTFE mash. Okay, you have onlay, unlay, whatever it is. What is the most important thing in the mash when you choose a mash? Which team?
Team A.
Team A first, sir.
Because bowel is exposed, sir, we should be using a composite mesh here.
Okay.
to prevent
Okay. This is
adhesion.
not the answer. Other team?
Sir, the nature of the mesh has to be decided based on the
So
level.
both are wrong. 0 for both.
Okay,
Second
sir.
question. Second
You give the
question.
answer, sir. You give the answer.
Answer is it is the pore size.
Pores.
Pore size. Why it is important? Next question. Why pore size?
To team B.
For
More
incorporate.
the pore size, more it will be it will grow through the pore and incorporate better. So higher pore size is better.
Okay. What is the disadvantage? It
No,
incorporates better. What is the
He
disadvantage?
has told some answer, but I have not given the yes or right or wrong. So he said pore size or number of pores. Pore size, huh?
I told pore size, sir.
Pore size. Okay, pore size. Okay, pore size. So this is the important that yes, pore size. That already we discussed first question, pore size. Now question is size of the pore. Which size you will choose?
Higher
Whether
size.
it
If
no
we are going
higher lower. There is nothing like higher lower. You correctly tell na, because you are reading the material you are ordering. It may be PTFE, it may be GOTA, whatever it is, but you have to check very carefully. And why it is important in the abdomen?
because when we
No. Wait. Pore size. Tell me the first pore size. Over to the other team. Pore size.
Team A. Team A.
So they can be we will be choosing a macroporous mesh, which would be more than 75 micron.
Wrong. Madam, both 0. Both
Okay,
0.
sir.
So the answer is 10 micrometer. 10 micrometer. And the answer is no. Again, if it is 10 micron, then question is why 10? Why not 6? Why not 5? Third question. Answer is given now. Pore size. Second is size of the pore. Then why 10 only? What is the relation? Why they thought of making 10 as the criteria? What is the size of macrophage and neutrophil? Tell me the size. Because the neutrophil and macrophage size is more than 10. So bacteria will grow, but we don't want bacteria. What we want? Actually, we want granulation to come. So macrophage and neutrophil. So that is the reason they decided 10 micron. Oh, madam, that's all from my side.
Okay, sir. Thank you.
So 0 marks for this also for both the teams.
Okay,
So three
Both the
questions.
teams.
Yes, madam.
No marks. Okay.
Bhattacharya sir, you
Yeah.
would like to ask anything?
Uh,
Sorry, you contribute, sir.
yeah. So with due regards to all, I have seen the headlight on the abdomen has been practically avoided. I mean the bulge, which we are seeing. Okay. So what is it? It is certainly not an expander. It certainly not a myocutaneous flap. Possibly it is, there can be two. Either it is the herniation which has been grafted, or a rectus muscle turnover flap with graft. So if it is the viscera which has been grafted or the peritoneal area which has been grafted, by examining it will be compressible. If it is a muscle flap, then we should be able to see a turnover area, may or may not be seen. Most likely it is a muscle flap, because if you see the graft criteria, it is same as the rest of the abdominal grafted area. So maybe the muscle has been turned over and grafted in continuity. Now, the other input is, it is not always necessary that you have to put a muscle or myocutaneous flap. If you foresee a mesh supplementation in future, then even a skin flap is adequate. without sacrificing the rectus muscle, because that itself causes anatomical disbalance. And the third point is that if you have to see this patient, you need not, you will certainly require a big area, a big flap. It is for the PGs, I would like to emphasize that it is not always necessary that you plan one flap. Depending upon the availability of adjacent tissue, you can use two flaps uniting in the center. So thereby, the dimension of the flap reduces and the vascularity is protected. So, and in future, you might have to supplement with mesh if need be, as has been highlighted by Dr. Chitoria as well as Dr. Anjali, the types of mesh, etc. But that will be as a secondary procedure. Usually, mesh is not in electrical burn used as a primary procedure because there is always a chance of infection and rejection. So this is what I wanted to highlight because I am still stuck with that bulge. And maybe whosoever patient it is will be able to highlight what is that headlight is made up of.
We'll show the follow-up of the case.
Yeah.
Thank you, sir. Thank you very much.
Ma'am.
Any other faculty would like to ask? Otherwise, we
Can
can
I
proceed
have
to
one
next.
question, ma'am?
Sure, sir.
One
Sure.
question. Yeah. So team A, I'm asking, you have been, the panelists have asked almost local questions to all these and been very nice. I think all questions have been answered also. So my question is, in this case of electric high voltage above 1000 kV, what is the neurological symptom the patient can have? Team A.
Neurological
Common
symptoms.
neurological symptom.
Early symptoms, there can be bleed in the internal hemorrhagic complications like
I am
bleed in the
asking
internal.
neurological.
Very
Very specific.
seizure, confusion, dizziness, and then peripheral neuropathy. It
No,
can be
no, no,
spinal
no,
cord
no,
injury.
no. Be specific. One thing we find in most of the electrical burns.
Loss of consciousness.
No. That also patient comes to you not in loss of consciousness. Might be there for transient time. To the team B, can you answer this?
Ataxia.
Team B?
Ataxia
Yeah.
or
Yeah, that's all. I don't want more. Team A, second question. You are given full marks for that.
So
Team
the
A.
pass, sir, that
Team-
passed on to
team-
team B. So we give 1 mark to team B. So the question should now go to team B, sir.
ma'am. Yeah. Team B, can I ask you? Hello.
Yes,
Yes,
sir.
sir.
Are you able to
Yes,
hear?
sir. Yes, sir. Yes, sir.
No, I mean the PGs, can you hear me?
Yes,
Yes,
sir.
sir.
We can
Yes,
hear,
sir.
sir.
Okay.
Team B.
Suppose there is a wound of entry and exit, and it affects the skull. What are the structures that are likely to be damaged in the skull?
The inner table, the outer table.
Yes.
The pericranium and other subcutaneous tissue, galea, and the skin, since these are deep burns.
Anything else? Team 1, can you answer? They have given in add to the answers they have
Dura.
given.
We can extend up to the dura, sir.
Till the dura.
Dura. Okay, you have answered then. I think I am finished with my question. Thank you so much.
Thank you, sir. Thank you, sir. Meanwhile, Rohit?
Madam, I will show the follow-up photos of spotters, ma'am.
Yeah.
Uh,
By the time the judges will give the result, we'll go through the spotters. We have follow-up of the spotter too. Dr. Anjana Malhotra will tell you what she has done for the spotter, this patient. Dr. Anjana? Madam is there?
so, ma'am,
Yeah, actually, this as we had shown, this was a 70% burns, and it was mainly second degree deep, as Professor Bhattacharya had pointed out then. And this child had a groin burns also, which was again very difficult to manage in the initial stage. So we went in for early burn wound excision, but we could excise only parts of the burns by 5 days and started covering. As Professor Bajaj pointed out, he was in sepsis for quite some time, and the graft, so we put cadaveric graft to begin with. As you could see, he had very little autograft, and then we used the sandwich technique in many places, and finally we were able to get him to heal. And we had to also take the use of meek micrografting. This question was also asked because of the paucity of donor sites. So this meek micrograft was used in the back and in the abdomen. Next. And you can see him, this is almost at just before discharge. We still have some areas of granulation tissue left to cover. Next. And this was him at 1 year. You can see he came back with a contracture at the lumbar region, which was being asked to be splintered. And then we did a Z-plasty, and these two raw areas we covered with Integra. Next.
Oh, one
And
slide
now
is
you can see
missing.
his delayed follow-up. He's still following up with us. And now you can see his delayed follow-up, the pin showing the area where the Integra was applied.
Rohit, one more slide is there. The umbilical area also, peri-umbilical, she has released.
1 minute. Yes.
Yes, so
Yeah.
you can see that apart from that lumbar contracture, he had contracture in the periumbilical area. And this is how we released it and gave a graft all around. And this is him, he couldn't squat at that time because of the groin contractures. And you can see now in 2025, him on follow-up. So this acute burn occurred during the COVID period in 2021, and this is a delayed follow-up, 4 years follow-up in 2025.
Okay, ma'am. Thank you. Madam,
Thank you, ma'am.
would you like
So next spotter.
1 minute, ma'am? Spotter 3.
Yeah. This is related to the spotter 3. Actually, this is a case done by Dr. Pradeep Gupta sir at Jaipur SMS Hospital. So a few more acute pictures were there. This is at the time of presentation, electrical burns with the flash burns. There was a deep wound. So after conservative management, and this is how they treated and grafted. So, and he presented after a few years, I think, with the hernia, as Dr. Bhattacharya sir rightly pointed out. And the discussion also done for that. So they that was treated with the mesh, and pedicled ALT flap was given. So this was treated at Jaipur SMS Hospital. Thank you. Next. You can invite Dr. Uma.
Take feedback, ma'am.
I think the final, yeah, this is another photo by
This is Anjana, ma'am.
Anjana ma'am. The patient treated by Anjana. This is, yeah.
It was covered in the papers because during the COVID we continued to work. So the Times of India covered this case.
Excellent treatment, ma'am. Wonderful.
Thank you so much.
Congratulations.
Thank you so much.
Madam, congratulations. Dr.
Thank you so
Chaudhary.
much, sir. Thank you.
Really inspiring treatment. We too treated like that only during COVID period, around 50% burns in 9 months child.
Highly appreciate.
Okay. Rohit, you can go ahead.
Yes, ma'am.
Thank you, sir. Thank you.
Just Umar sir to kindly
So,
take.
good evening to all. After this whole
Good
engaging
evening,
session,
Dr. Umar.
good evening, ma'am. Good evening to all. It was really engaging. So, all I think that delegates, everybody was totally engaged during the whole session. Wonderful. So, we'll start with the feedback. So, we'll go first to the
So,
panelists.
open, Umar. Anybody would like to give the feedback, let them.
Let us start with the panelists first, then we'll go to the individual person. Let us start with the panelists. Dr. Shalab, sir.
Yeah.
Good
So,
evening, sir. Good evening.
very good evening. Very good evening. Very good session. I think many topics they have been covered, and the teams were also very good. They answered quite a lot of things, but some things are lacking. Okay, that's what happens. So overall, very good session. Very good session.
Thank you, sir.
Thank you, sir.
Anjana, ma'am.
Yeah,
Congratulations, first of all, for
excellent
the case.
session.
It was really wonderful.
Thank you. Yeah, excellent
wonderful.
session and a very good discussion. And every different aspect was covered. I felt both the teams are very good, very well prepared. And I would like to actually thank the whole team of Plastiquest, led by Dr. Lakshmi and Dr. Bhattacharya, for taking the effort on every Saturday evening to do such exhaustive work. And actually, it's helping the PGs a lot because. When they answer questions, whatever we have taught, at least they know how other examiners ask and how to reply.
Thank you, ma'am.
Thank you. Dr. Ravi Kumar, sir. Ravi, sir.
Excellent feedback from my side because it is a really honor to see our teachers and then their further expert comments so that still we feel I am a student. And also the team headed by madam and you and other people. So I'm really very happy, and our students keep discussing after even this session during our round, and I keep telling that every day is a Plastiquest day. Don't wait for the Plastiquest day. Every day is a Plastiquest day. So and thank you for inviting me and giving me this opportunity. Thank you, sir. Thank you.
Thank
Thank you, sir. Now we'll go to moderators. Seema Rekha, ma'am. She is here. Seema, ma'am.
Rekha, ma'am.
Yes.
Good evening, ma'am. Good evening.
Yeah, good evening, and it has been a very good session. I congratulate all.
Thank you.
And really, it was conducted also very well. I wish, the students will come more and more to learn from all these deliberations and question asked. And especially congratulations to Dr. Anjana for a very good case presentation. So
Thank you so much.
I'm really thankful for being here to Dr. Lakshmi.
Thank you, ma'am.
Thank you, ma'am. Thank you. Malti, ma'am.
Okay, thank you so much thank you, Lakshmi, for inviting me. And this was a very, very interesting session. And the high tension electric injuries is it's a favorite topic of mine. I've been talking about it in many conferences also. And I hope, and I of course congratulate Anjana and everybody else, but mainly Anjana for whatever she has shown here, the child that she has been operating upon and following up. And I think the teamwork was very good. The students have prepared very well. And I have a complaint that I was giving too little time. I think I wanted to ask a few more questions.
Ma'am, you can ask. Now you can ask, no problem at all.
Now it's
Sorry.
over, but what Vishu had taken up, the bulge on the abdominal wall was my next question I wanted to ask, and I'm happy that Vishu took it up and gave all the details about it. It was very important.
Who is Vishu?
Vishu is Vishweshwar Bhattacharya. That's I always call you Vishu. so-
Honored, sir.
Sir, we came to know
Yes.
about how sir, madam will call you.
See, his name is so long. So since day one, I don't know whether he's really joking about it or he's forgotten. But that's how I
No,
used to
very well.
address you.
Yeah.
Sir will not
So,
forget
Thank you,
at
ma'am.
all.
Thank you, ma'am. Now the
Thank you, sir.
turn of Vishu sir, Bhattacharya sir.
See, the beauty of our specialty is that the same thing can be managed in different ways according to the choice and experience of the surgeon treating. And that's
Yes.
what we see most of the time when they show the follow-up of cases. And the other thing is by listening to the very rewarded and learned faculties, I always try to appreciate how much I do not.
Yes, sir. We are learning from
Always
each
learning,
other.
always learning.
Yeah.
Always learning from
So,
each other.
yeah, so that makes me feel how much I do not.
Thank you,
Thank you.
sir. Now we'll go to judges. RK sir.
Excellent. And time management is also better.
Thank you,
But
sir.
still, I would like to say that the first spotter gets too much time.
No, no, sir. No, not at all this time.
Now it
Almost
is by
45
watch, sir.
minutes.
No,
It is
no,
by
sir.
watch now.
First
Now
spotter
by
By
is
watch.
watch, it was first stopper was, according to me, 45 minutes.
No, sir.
So
No,
we can still
I agree
get
with
better
you. I
management.
agree.
no, no.
Yeah.
Salab sir joined little late. So there was
Okay.
some gap. I was watching that time only. First spotter didn't get long time. Last
Thank
spotter
you,
got
sir. Thank
more
you.
time. Last spotter.
We'll go to
But
Joseph sir now. Joseph sir.
otherwise, everything was excellent.
Vijay sir. Vijay Joseph sir. Vijay sir.
Can I speak 1 minute?
Yes, sir.
Yes sir. Yes sir. Please. Yes sir. Please.
Well, thank you very much to all the panelists. They're so nicely done with time management, which I've been saying. And I have been a student having till now at least 100% attendance on Plastiquest. So I have learnt a lot. In fact, with everybody has their own experience. Our Professor Bhattacharya has told that every institution is different in India and everybody had their own infrastructure and their plan of management. Obviously, the net result is the patient. If the patient gets cured, that is the certificate we all get. And this time, I am very much happy with Dr. Anjana Malhotra, ma'am. At least he has presented a very nice case and shown that the sun is rising from the east. So this is a pan-India from east to west, from north to south. After the Chinar Bridge has been inaugurated, Madam Lakshmi has made it a pan-India, connecting from Kashmir to Kanyakumari and from Guwahati to Mumbai. So this became a very good and favorite to most of the people in the country. So whenever I ask the young people, sir, this is one of the best possible thing for us and for the senior teachers like Professor Bhattacharya, Professor Bajaj, Professor Gupta, they are coming and participating so actively. I think this is a 3 generation of plastic surgeons involved with this type of interaction and interactive professional discussion. So thank you very much to all. And I think we should keep it up. And there have been some glitch in somewhere the timing and all that Professor Srivastava has already pointed out. But we have refined to a great extent. In future, it will be much more. And this is being viewed and recorded. And internationally, it will be also acclaimed. And one time, we don't know, I have already mentioned, this may go into the Guinness Book of World Records. Thank you very much.
Sir, thank you,
Thank
sir.
you, sir. Blessings.
Now, Vijay Joseph, sir. So,
Things
let us
are
go to
not be
Upal,
there.
sir. We'll go to Upal, sir. Sanjeev Upal, sir.
I think
Sanjeev Upal.
both are not here.
Okay, let us take the feedback from the teams, today's teams.
Yeah.
Team Bhuneshwar.
This has been a cumulatively a very good learning process, sir. It's a privilege to be able to learn from the best faculty all over the country. And we're very thankful to Lakshmi ma'am and the entire team of Plastiquest to give us the opportunity to be here today. Thank you.
Thank you. Now, other team.
Yes, sir. We are also privileged to be a part of Plastiquest, and it was a great learning opportunity, and we got to learn from masters of plastic surgery from all over India. So it was an honor for us to be a part of this, sir.
Thank you.
Venkat sir is here.
Sir is not there.
Sir is not
Sir
there.
hasn't joined today.
Okay. So let us go to the result then.
Anjana ma'am, Angelina ma'am?
Yes, please.
Yes, yes.
We invite the judges to announce the
So,
result, please.
Dr.
Actually,
Angelina
I
will
congratulate both the teams for doing very well. Actually, it was a tough fight competition. As usual, we have to select one person according to the score. So let me announce the marks obtained. Team A scored 37. Team B scored 44. So congratulations, Team B. You have been successful.
Congratulations to
Congratulations,
both.
teams.
Congratulations.
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 Thank you, sir.
Team B.
Thank you.
Thank you, sir.
That's
I
good.
want to congratulate Lakshmi.
Thank you.
She is the one,
Definitely, definitely.
Ma'am, she is
getting good
always
marks.
being congratulated and appreciated.
She is always
Every
getting
time
the
we
highest marks.
appreciate her.
Thanks a lot, sir. My Usmania team also shares that appreciation.
So Lakshmi
So
ji,
let us
please
go
convey
now to
my
the vote of
regards.
thanks
Yeah,
by
yeah.
Dr.
Devi.
Her also.
Devi.
Good evening, everybody. Myself, Dr. Mahapatra. On behalf of Lakshmi Madam, Umar Farooq sir, Rohit sir, who are the organizers of the Plastiquest, I'm really thankful. We come to the end of the session 4. I'm grateful to our moderators, Malti Madam, Bhattacharya sir, Simarekha Devi Madam, for your nice moderation and very good inputs. I'm also thankful to our panelists for today, Dr. Ravi Kumar Chituria sir, Dr. Anjana Malhotra Madam, and Salab Kumar sir.